And no. Lily. Issues are getting Lily. And have it is Lily. That's what I had maybe. Because whatever user I'm in doesn't have access.
I really love these updates.
Okay, in the back end.
I've been on, I have everything all uploaded and my keys as well.
You know,
Takes a while.
Yeah.
So,
Love that.
so he was gonna check with his.
Yeah, I feel like there's been a few features that I'm like, yeah, I'm not mad at the update anymore.
Was the new 11?
I-
Yeah, it's for your
Windows 11,
computer, yeah. Yeah, there's some cool stuff. Okay, Andrew, I'm up. There's some pretty neat stuff with the new upgrade, but it's just getting used to it
Yeah.
and looking for everything. You're welcome.
Got mirror to that mirror to that.
I just unmuted, Greg. That might be better.
Yeah.
'Cause when I unmute, you echo.
Okay, and so, there, we had a usual number of appreciations, historic awards, and cardiac arrest saves still continue to be popular. Again, I would encourage, we love doing that. It takes a lot of work. Please look at the personnel that are doing the actual response. I get everyone's on a response, but sometimes the cardiac arrest save, people will submit like 30 names. I get the team approach, but I'm like, we're 30 people involved in true patient care with this patient. So please be reasonable with those. Other than that, nothing further on the honorary certificates.
Moving along to reports, Indiana Department of Health.
It's online. It's Finucino.
Who?
Vince Finucino from Department of Health online.
No. He is? I don't see him there.
So maybe skip theirs, and if he joins, then we can come back.
We'll come back to that. Moving on to legislative update, Director Kim.
So it's been a busy legislative season. We start on January 8th. The projected end date's April 29th. We're hearing more likely like around April 24th is their internal goal. The budget, of course, will be the big thing that they have. And I do send out the reminders, but here are some of the deadlines. We have April 15th is the last day for third reading of bills. And if you recall, it swapped a couple of weeks ago. So if a bill originated in the House, it had to leave the House by then, and it's now in the Senate if it did, and then vice versa. And so the final date for the opposite chamber to hear it is April 15th. State budget is progressing. It does still include EMS readiness funding at $4.1 million per year and mobile integrated health grants at $500,000 a year. It's always subject to change as they do the final numbers. House Bill 1051 mobile integrated healthcare grants. The original bill was to add a county as an approved municipality that could receive our grants. And is amended for provider organization and hospitals and had a second reading, I believe possibly yesterday. I apologize, I didn't get a chance to look on that. And so that would be a difference. So it needs to have a second, third reading in the Senate. And then if it is adopted as amended, then it would go back for what they call a conference committee to see if there's agreement among both chambers. House Bill 1113 is fire protection districts, but interestingly, one of the key provisions is you can form a fire protection district for EMS coverage. And that would be a new reason that the fire service would be able to perform or create a fire protection district. House Bill 1118 is still pending, waiting committee in the opposite chamber, but it would create a privilege and confidential information for CISM, CISD, critical incident stress debriefings, which is important because that way people can speak freely as they're trying to do that kind of mental assessment and not have to worry about it coming out in a court case later. House Bill 1297 Motor Vehicle Medical Identification Program, nationally recognized as the Yellow Dot Program, is in the Senate and it is available as the second chamber since it is a House bill and it is eligible for a second and third reading. Essentially what this would be is a tool and it has some protections if you rely upon it. but if you see a yellow dot, then you can access patient history information. And so if this passes, not a direct pass for the EMS commission or our office, but we would likely need to do education, make sure people understand the program. And so we'll continue to track that. House Bill 1587, insurance matters, creates a sustainable pathway to cover MIH services. And it is limited to state plans because that's how it tends to work. But if it's added to a state plan, the private insurers usually are on board as well. So hopefully that will pass through. Again, it's in the opposite chamber now. Senate side did not have as much this year. Senate Bill 1, property tax relief. Just continue to monitor it. It is progressing to where I think it would have minimal impact on localities. But if you if it passed in its original form, that may reduce funding for localities and result in service changes trickling down. Senate Bill 505, emergency transport to appropriate facility. This is one we're very excited for. Dr. Yeasel's been a strong proponent. He testified in the initial Senate hearing. It allows for basically transport to healthcare facilities, mental health facility, or an urgent care facility. And it passed the Senate committee unanimously with an amendment. Interestingly, I highlighted there, the amendment was originally, it said that providers may be reimbursed if they go to those other areas. And fortunately, if it passes through, the Senate deemed that it should be a shall clause, so that way there's not the risk of not being paid for it. And so I think that's a big win, and it's eligible for second and third readings in the Senate. That is all of the legislative updates that I have of the major ones that have impact. So you wouldn't have any questions on that or the list as that gets.
Right, the Senate Bill 505, if that passes, will that have other steps on the insurance side that it has to pass to where they can work for that? Is there that end of it's gonna have to do that?
Again, I believe the way it regulates insurance is so weird. The way it works is I believe this would mandate Indiana Medicaid through FSSA and state healthcare plans, which they have direct control. But for the private insurance, I think it would be, they would have to evaluate it, but they do tend to take their lead after the state programs. Good question.
Further questions for Director Kent? Hearing none. EMS for Children update, Margot Camillo.
She had indicated that I don't know if she's online, she said she did not have a major update. They are kind of caught in the government review right now versus kind of under the microscope. And so they're waiting to hear whether they will continue to receive funding and such. So definitely keep them in their mind. If you do have legislative contacts from the Congress level, they would appreciate you showing the support. So that's the main update that she had.
Moving on to Indiana Fire Chiefs Association, EMS Division, Chief Jared Starks.
We don't have any major updates. No
He's
major
on my
updates.
speak. He said no major update.
I did put in a slide, this reminder, their
announcement.
conference is September 17th to 19th this year, still in Noblesville. We did not have a big EMS turnout last year. Megan Teely has said she wants to beef up the EMS offerings and hopes that EMS will strongly participate this year, so.
Moving on to Indiana Emergency Medical Services Association, Nate Metz.
Okay, cool. Hello, everybody. A couple brief updates for you all. We got a lot going on. First thing I think I'm going to talk about here is to make sure that you guys understand we got a couple of different events and a new one on the schedule to look out for. We have two events on the same day on May 17th. We have Running with Shears in the morning. Registration for that is open. People are signing up now, so make sure you go and register for that. It's a beautiful 5K walk and or run available to kids, everybody else down. That will go on in the morning. Then after that in the evenings will be our Golden Siren Banquet. Registration for that is open as well. There is a hotel bank if people would like to stay the evening. That is available until April 14th. There is a link on the registration that can take you to that hotel bank, so you can get a different room rate if you so choose. Of course, you don't have to do that if you don't want to, but that is available to you all if you want. And make sure that you do those registrations. Also with the Golden Siren Banquet, provider awards are still open until the end of the month. And so if you have anybody that you would like to honor in that realm, please do so and submit that. But again, that will close at the end of the month. A new event that we will be doing this year is going to happen in the southern part of the state down in Vincennes, and that is actually going to be a benefit poker ride. And that will be for the EMS Memorial. It's going to happen on September 6th. There is a park down there in which we'll launch from, and we'll have more information on that coming out here shortly. But we know that's going to happen on September 6th. It's a new event for us. So if you know anybody who likes to ride, make sure you let them know that that's available to them. And then, of course, we have our Crossroads Emergency Medical Conference coming up. Pre-con will be on the 19th, and we'll be going 19th to the 21st. A lot of the same people are going to be back from the pre-con. So there's going to be a lot of really good stuff there. Yeah.
Do you know when it's gonna open up for abstract application?
It's open, it will open probably this week. We finalized the abstracts yesterday.
Okay. Thank you.
Much. Okay. A couple of changes you guys are seeing out, there's gonna be a slew of them, so I ask you guys to have patience with us, a little bit on these things. We are a volunteer board, but I'd probably say we're kicking butt on it, considering. First couple of things you're gonna see is that there is going to be a new membership platform that we're gonna be pushing our members into from the old one to the new one. This is actually paired with a new website as well. And so for a lot of you guys who are members, look for some emails coming out as we transition you to this new platform. This new platform is also going to allow for some additional benefits for memberships. There's almost like a little group in our website that includes a social media area, that includes a file drop, that to a bunch of different resources, shared documents. We're going to be able to run some educational events through that platform as well. So keep an eye on that. Look for emails coming out. You'll probably get a message saying, hey, please log in or sign in to create your new profile in the new system. You can do all on that one as well. So if you know that your membership or something's about to expire, we're probably not gonna kick you out until we get you all transitioned over and stuff, but just make sure there's a good open line of communication with that kind of good stuff. We are re-exploring our benefit membership package. This is something that hasn't been done in probably 14 years with the association. Prior, we used to do our membership based off the size of ambulances, the number of ambulances. We're actually going to try to change that. The membership committee has actually put together a little bit of a plan. Hopefully we verify it today. But they want to base it off of number of employees now. Rates did change just a little bit, and then we're working on a couple of different membership packages down the way as well. This will also impact, well, we're hoping it will actually impact individual membership too. Reason why we want the rate just to go up for again, remember this is an annual membership fee, is so that we can bring some more benefits in to actually provide back to providers. So keep an eye out for that kind of good stuff that's coming down. There's going to be some changes on that front. Again, the transition is going to be interesting, but bear with us. In addition to that, we also have a new website that will be going live here probably by the end of the month, would be my guess. So check that out. IndianaEMSassociation.org. And there's be a bunch of really good stuff in there, including the newsletter, news articles. We're going to be attaching some podcasts into that particular site too. We'll be able to put all these meetings and all these kind of things on there as well. So just keep an eye on that as we approach. The site is live right now. There's a couple of pieces that still are not visible. We're still working on building. So you'll see that evolve continuously probably over the next year. All right. The other thing that we're doing is that we're trying to push and develop an administrative side to our organization as we grow. And so you might even see some emails come out from folks with different domain name and stuff too. Always check if you're concerned about the email, but chances are if it has that domain name, it's from one of us. It just might change from the domain that you originally knew, or a lot of our own personal domain names whenever you guys try to communicate. So you'll see a transition of that to come down. So don't be shocked if you see an email come from me that, says Nate at Indiana EMS Association as opposed to maybe one of the other ones that we're talking about. But I think that's pretty much it. There are a couple of new ideas that we are wanting to do this year, and we'd ask for you guys for your support. These are not things that are effective. We don't have dates. These are things we want to try to build out coming into the new year that we'd love your guys' support with. One of them that we're currently actually trying to work on achieving is a mental health and resiliency training seminar that goes on through the course of the year, where we could actually take this kind of event to different regions all over the state to help do resiliency training and mental health training for departments and for individuals. Start to get them to explore the idea that, hey, you know what? Taking care of our mental health is not a bad thing. Another thing we wanted to try to do is online continuing education program, where we can maybe use this platform for something like that. And then one of the other things that have been talked about as far as an idea, especially in relevance to our banquet, our awards banquet, and we look at, you know, organizations like the Fire Chiefs Association and even you guys' own organization. And all of us award and recommend and accommodate different providers for the work they do, and that's, we should, right? But we wonder if there isn't a way where we can maybe create an MOU where we create a EMS professionals in our industry that we kind of all recognize. And could that combination system then be pushed to help create a more professional look and feel for our particular industry? And, you know, maybe each of our different organizations can kind of, you know, can be included in that, and where, you know, your guys' Star of Life is this kind of accommodation or what have you. And, you know, IRC has their accommodations and et cetera, but they're uniform across the board. And so that's one thing we'd like to have discussions with, if anybody would be interested in doing those kind of things. Yeah, so that's a couple of the new projects going with us, and appreciate your guys' time. If there's any questions, I'd be more than willing to take them, but that's pretty much it.
Any questions?
You can leave it up there. Department of Health, Vince did email and ask for the logon information. I don't know if he's joined.
I've already sent it to him.
Looks like he's on.
Come on.
We'll circle back to any other part of the bill.
All right, thank you, everyone. Sorry for the confusion here. I'm off site, so I had a little bit of a difficulty getting in here. So thank everyone for having us here. I know you got a tight agenda, so I'll be quick. Our mission and vision, really looking to make sure that we take care of all Hoosiers, promote, protect, and improve the health and safety. So pretty solid goal, I think, for any of us at this meeting. You can go to the next slide. I want to give a quick update, particularly for this group. So our Trauma Care Commission met on February 7th, and one of the awarded grants, we have 13 so far that have been awarded, and there's a few more in the pipeline. But one of them I thought most interesting probably to this group is that we just approved a district-wide funding for blanket warmers on all their EMS trucks. So I thought that was pretty cool, and I wanted to make sure I shared that. And another one that we approved was for injury prevention, mainly looking at firearm violence and what we can do to have some intervention and support services around that. So those are some grants that just were awarded, and we'll start soon. So, and if anyone thinks that they have a grant they want to write or be interested in for funding, that's the link on the slide. So please feel free to look into that. We still have for FY25, the grant period is still open. Knowing we're running out of time for some of these things don't happen immediately. But if you think you got an idea that maybe we can help fund, please take a look at that and let us know. Go next slide. This is another one I want to make sure I shared with this group, and some of you may have heard this through my regional clinical coordinators. The Rural Health Innovation Collaborative, known as RIC, is also a grant awardee. Started in, they won back in December, but they started their first of many trainings this past January. And they're going around to critical access non-trauma centers and hitting some like basic, I don't say basic, but some essential trauma skills, making sure that the teams are up to snuff, seen some of these things, because we know that despite not being a trauma center, they're very much part of the trauma plan for the state. And this is open to all of our EMS, paramedics, anyone who would want to attend. These are free. We're going across the state. So you can use our website. There's a link there to find out what areas. They're not all scheduled yet. We have, I think, about 10 or so scheduled. So great opportunity if you're not, too far away, or if you want to make a ride. There's QR codes on all the registrations, and it's all free. And it's been really well received so far. We just did one at Decatur County yesterday, and we have plenty more of them coming up. And if we don't catch your neighborhood right now, keep an eye, because we're looking to do about 14 this year and then some more next year. So great opportunity for some hands-on and free training, which is not always happening. Next slide. So we did have our first statewide trauma and emergency medicine symposium this past December, and those are just some photos from some of the sessions that happened. We did some training on day 2. You can see there we had some geriatric emergency medicine, some trauma registry, and peds trauma education classes. So just keep an eye out. We have another symposium coming here for 2025, the beginning of October, trying to be a little more conducive to the weather and get away from that busier time of the year we know that we hit in December. So that's looking to be in Bloomington, last I heard. And I'll have a lot more opportunities for attendees. It's a bigger venue. This is just an example of some trainings that we've done so far with some of the funding that we've had. You can certainly look at that whenever. Next slide. Some of the priorities coming up for 2025: continue to implement our trauma system plan, working on our trauma regional advisory council. So tracks, you may have heard we have a north, central, and southern track. So we continue to build that out, and there should be representation and from some of your EMS leadership should have been invited. If you're not and you want to find out, please feel free to reach out to me or anyone on my team, and we will get you some information on that. You can go next slide. And this is the regions I was just speaking of, and the regional clinical coordinators for each of those areas. So these folks are out and about trying to meet anyone they can, right? We're at HCC events, we're at facilities. We want to try to put this together and kind of break down some of these barriers to communication and find out what everyone's doing so we can better be prepared for trauma across the state, regardless if it's a large trauma center or if it's a critical access, kind of in the middle of the woods. So these are the folks that are out there on the ground. Feel free, if you got any questions, reach out to them or myself. We're all here to help. Next slide. Just some ACS re-verifications, letting you know these centers are going back up for renewal. You can go to the next slide. And next slide. I won't go over all these slides. It's just some data just to kind of give you this background, see what's going on. Trauma incidents by quarter have slowly been creeping up, as you can see. Go next slide. And here's just some more different demographic information. Again, I won't take too long on these things. You guys can certainly check these out. Next slide. If you weren't aware, falls continue to be the leading mechanism of injury across the state. And I think the next slide will show you even an age breakdown. Yeah, so it's falls across the board. Pardon me. Next slide. And we have a couple slides here with some just information, just showing you ground ambulance is by far the leading mode of transport to the initial facility. And again, this is excluding interfacility transfers. Next slide. Just give you some ideas between the different preparedness districts, the average times on times to facility. Next slide. Again, another way to look at it between travel to scene, at the scene, and then transport to facility, kind of putting it together for each district. And next slide, please. This is just part of what we're working through. Our data and surveillance team is growing and is finally kind of getting settled in. So we continue to look at gaps in the analysis for validation of the data so that we can continue to put out quality reports. And it's continues to evolve and improve. So some of you may be a part of this or may be reached out to in the future, just depending on what part of the project we're in. So just know that we're looking at getting better and better data, and it is a focus of the department and the division. Next slide. So here again, contacts. There's the regional clinical coordinators. I'm on there as the clinical director. We have Ramsey, who many of you probably know, and then the data and surveillance team, Lauren Milroy and Alex Marslander, can help if there's anything from a data perspective or any questions about how it's being collected. Next slide. So the next few slides are around the CARES program. So it's a cardiac arrest registry to enhance survival, I believe is what it actually stands. Yep, enhance survival. So this is a really great opportunity. We are now partnering up we as in Indiana, looking to get this registry to get more data to, again, better take care of Hoosiers and find out where some of our opportunities lie. You can go to the next slide. So, and this is going to talk a little bit about some of the benefits to it, the collaborations between EMS, hospitals, health agencies. There is another, I think the next slide talks about this program right now. This registry is free and it syncs up. It's, from my understanding, completely compatible with NEMSIS. And if you have any questions about anything with CARES, Moses is our guy there, and his contact information on the screen. Please let us know if you get any questions, because this is a great opportunity, and we're excited to kind of work with this registry and collect this quality data and again affect the lives of all our Hoosiers in the positive. So I think that's my last slide. If anyone has anything for me, that's my contact information. Again, I apologize for being a little bit late. I do appreciate the opportunity to speak with everyone today. But if I can help at any point, don't hesitate to reach out. Thank you very much.
Any questions for Dr.
Comment out, Dr. Yeazel wants to add on the CARES that it's collaborative with us, and he's been engaged in that.
Yeah, we're, Moses and I meet, we have a scheduled meeting, discuss it. Start out with outreach to some of our services that are already utilizing it and expanding out to some of the ones that are more interested in engaged. So at some point, all of you will be hearing from us, and we look forward to being able to provide that data to our services all across the state. It would be a really nice resource for everybody.
Next up, Education Oversight Committee, John's on.
We have nothing to report at this time.
Mobile Integrated Health Committee.
Similar to when we canceled January meeting here, part of the reason was because we didn't have any mobile integrated health applications, so we do not have any for approval. We will have one for next time and hopefully more, because we'll have a couple of months to get them in. But we are still meeting. We do have subcommittees at work. We're hoping this will be the year that we can finally maybe look at some rulemaking for creating standards for mobile integrated health, including background credentialing, things like that. We're getting much closer to that. Our next meeting is Friday, April 11th. They are out here at Maid at 10 a.m. We do offer a virtual link, so if you're interested, get with Emily Castor, our mobile integrated health coordinator. She will connect you. Only other announcement we have is that several conferences going on at the national level. Dr. Yeazel is a board member. They had a tech and prep conference in Tampa, February 17th to 20th. And then there's the Atrium Health NIH conference in Savannah in a week.
Any questions for Rick? Yeah. Moving on to new business. Any MSA new one?
Greg, they're asking if they could be provided the PowerPoint slides for reference.
For what?
For reference, they'd like to know if they can get the PowerPoint slides.
It's too voluminous to send out, so
Okay.
I send the EMS commissioners. We can probably post some of it.
Okay, Sonia Hughes.
Okay, the annual report. We'll see if I can reclaim my voice from my allergies. This will be emailed out, I believe sometime today, probably during this meeting. We worked with our PIO And this will be our third annual report we've done. And so 2024 is the year. As the introduction, it does have kind of highlights of what we've done. If you're wondering where we've been, what conferences, things like that, you can find that in the annual report. There are pages on the EMS Commission. So I know sometimes we get questions, and that's a common one, where they're like, which commission meeting was it that they approved this or they approved that? This is an excellent resource because we go through the minutes and we pull out all of the action items. We do have in there, we have our structure chart, and then we have explanations of what everyone does and pictures. So if you've seen people, I feel like most of you, I recognize everyone. Most of you probably recognize our staff. But if you're like, I always see that person, I have no clue who that is. You can look in here, except for poor Jamie. She'll get introduced later, but she wasn't here in 2024. We did have a nice send off for Don Watson and kind of the coverage for his retirement as well in the annual report. There is a legislative update from last year. And so these are excellent resources if you're also wondering, hey, I think a bill passed 2 years ago. All the annual reports are on our website, so you can go back and look and just get a quick synopsis of the bills impacting EMS. We have a health first update in there, which would be how we are spending the EMS readiness funding. And if you look there, there is the division of what we have. And so basically, between equipment grants and traditional education were the big two. But we have money reserved for the inter-facility pilot too that we have not distributed because of, and Dr. Yazel is going to have an update on that later. But that gives you an idea of the spending categories for fiscal year 2024. That's the annual report for 25. I'm going to have an update up here later in my report. We also do have highlights of the Indiana EMS 2025 report. That report's on our website, but you can find it in the annual report as well. And I actually went through and pulled out the highlights. So if you want a brief synopsis, that is in the annual report for you. Honorary recognitions, you can see them there. And you can see the cardiac arrest saves were ones that we developed at the request of providers, and you can see how much they have taken off. Last year, they were closing in on Stork Awards that were the most popular, and now cardiac arrest saves are the most popular. As the other stats for how many we gave, we also were fortunate last year. Last year was a break, and we had no EMS line of duty deaths. There were some fire deaths related to cancer that held EMS first, but they were not EMS line of duty deaths. Certifications, our audit information's in there, administrative orders breakdown. I would note when you see that it was dropped down because it was about double that. And that had to do with the year before where we had one organization that had like 10 to 12 people that were sanctioned. And so this year it was more normal, but it takes staff a while to investigate these. It usually takes me at least an hour or two to draft the order. Legal then reviews it, and it goes through a whole process. So when you're looking at that many, that really is 26 every other week we are doing one, and that's a lot of time consuming related to certain sanctions also take a certain amount of time to do. If you want to know about new certifications, we have new information there, and our section chief Corey Wells did a good job. We have some new visuals that make it easy to see in the report. The visuals up here were his original. They look slightly different in the report, but it's easier to see here. So go to the report, you'll be able to see the different certification levels. Not surprisingly, EMT is the largest one that we have out there. When we look at the trend, and this is my graph that I use, and the trend still is pretty stable, but we know there's increasing needs, but it did go up a little bit from prior years. And actually, the big news was that we hovered around 24,500 for several years, and we actually breached 25,000 at the end of the year. And so we do have an increase in the number of certified people, probably not enough to fill the shortage gap if you look statistically, but it still is a good sign that it went up to 2.6%. We also have retention rates, if you want to know. And what we factor in there, we factor number of people eligible, how many renewed, how many did not. But we also take it a step further, so it's not exactly retention. We look at kind of what I would call the backfill, the new people that are coming in, and you can get a quick synopsis of how we are doing by looking at the annual report. Ambulance providers listed there by the different type that we have. Of course, fire-based is the volunteer fires, the biggest number, and that's due to the number of BLS non-transport organizations that we have. Volunteer ambulance would be behind, and then hospital, government, and paid. And then here is providers organization by the type that they are as well. So if you're wondering where you fit in based on the type you are, the annual report will be a good way to look at that. And then we have the certified vehicles by type, and of course the ground ambulance is the most significant. But we have a fair number of ALS non-transport, and then we do have the air medical listed.
We got a question online. It says, do the certifications contain the honorary ones as well? The 25,000? No.
No, those would only be active certificates, not honorary. Good question. With this chart here, there is not, if you notice, and you're wondering, oh, well, how many non-transport at the BLS level? Why do they not have that? With BLS level, we don't certify the vehicles because it's with the organization, because we know a lot of times they may switch. It might be on an engine and they might bump it to another one. So they have to verify they have the equipment with the organization, but the vehicle itself is not certified. Whereas ALS, the vehicle is certified, so we can actually get the numbers that we have for those. Annual incidents continue to go up, and Kim Foster has been on leave for a while, and so Robin supervises operations, and she's been involved. She looked at the numbers just so that we don't get questions. The numbers, sometimes you hear it change slightly in terms of the number of runs we had, and it even changed from the time I initially listed them and we finalized. And the reason it changes is we use the most accurate current number. And the problem is sometimes we find a provider that hasn't reported in 3 months. And so that means they have data from 24. And if they get it submitted, that's going to change that run number. So that's why it creeps up just a little. Because our compliance is usually in the 90%, it shouldn't go up a bunch, but it can fluctuate just slightly. We also have a report of mobile integrated healthcare. If you want to see what has happened there, you will be able to see that in the report. And then we have lots of training information that Carrie gathered for us. And you can see there the certified training institutions. We actually have more ALS than BLS, but we have 136 total that are out there. And then when you look at the pass rates, our pass rates continue to improve. We always want to continue to strive for even more, but they did go up when you look at. We still struggle against the national level, but it still is an improvement that we have. The SimLab usage has been a good success story. And we actually, I have noted here, both the deployments, the time we go out, as well as the number of people we interact with have increased significantly. And if you go back to when I became director in 2020, it really has almost doubled, from that time. And so Tim does a great job. And we've also kind of verbalized, encouraged people to use that free resource, and you guys have been doing that. Then we always close out with the final word from Dr. Yezel. Both my intro kind of captures a more technical what occurred, and he does a good job of the feel of EMS and where we are and the accomplishments and the challenges that we've had. So you can find those in the annual report. I'm open to any questions. As I said, that should be emailed out, should be on our website for people to look at as well as a media.
Move on to EMS mental health mandatory training.
So on this one, and Carrie to help me in a minute, but we had a change of law back in 2023 that added Indiana 16.2, added to 1631.32, said the commission by the end of last year should require that we have training for our responders on responder mental health. If you recall, we do have had for years suicide awareness, but this included some additional elements like PTSD and other items such as that. The reason we have it on the agenda today is because we didn't have a program to approve at that time. Our office partnered together, and thanks to the actions of the State Fire Marshal and the Fire and Public Safety Academy, they funded a expert to create a program that met the statutory requirements and would speak to all responders. So that way, it also helps for the fire base and for our fire representatives here. So you don't have to take the fire version and an EMS version. It's the same version that is out there. Now, the fire service, it is interesting. It's on the organizations. The fire departments have to say, we're compliant, our people have done that. And that's because a lot of their certs, you earn them and you have them until they don't expire. And so with us, because we have expirations, it is tied to our expiration for renewals. And so we finally have that training program, and here's where I'll ask Carrie to speak to, because she kind of took a look at what they came up with, and then that tailored our recommendation.
Oh, actually, it'll be in my, it's one of my slides in the, for my education. So you just want me to wait until then?
It's the same stuff.
Oh, it is the same stuff. Okay. So, we are, it's real easy to find. So there's 3 courses. As you can see up there, there's a suicide awareness, a psychological health toolkit, and a resilience and the mind and body connection. I haven't had a chance to go through them yet. I plan on going through them ASAP, hopefully next week. But the easiest way to find those in the CADIS is when you click on the filter, is to just under, I think it's like topic, that first line, just put psychological, and all 3 of those will pop up. So it's really easy to find.
Your slide is later on, but yeah. So for now, though, the main part we wanted to cover, their suicide awareness, which would be an updated version.
Yeah.
Their psychological health toolkit, and then resilience and mind body. They offer all 3, and our recommendation is that responders take all 3 of them. And we don't believe it'll be time intensive to do that.
And I think it was Brendan Dryman that developed those programs. And if you've ever been to the leadership class where he does his presentation on mental health, he's an excellent speaker, very well known for his psychological, preparedness for EMS and fire. So I think they're going to be really good programs.
And I will say, if we decide if we're using this, and then for whatever reason we decided we wanted more EMS specific, we could look at it. We just need to bear in mind that if we do something different from fire, sometimes that will create a discrepancy. So our recommendation is that for all EMS candidates, whether they are EMR, EMT, advanced EMT, or paramedic, that they be required to take it as part of their initial education offering. And then as far as continuing education, that it be a part of the commission assigned education that you could do. And when we look at the possible rulemaking on Article 4, you'll see I have a line in each one that talks about the responder training. And so the recommendation today is that to comply with the statutory requirements, that we require both the new candidates as well as existing certified persons to take it as part of their continuing education cycle, and it'd be those 3 courses. Yes.
You said it would be time intensive, but do you have an idea, rough idea of what each course?
I do not.
If you give me a second, I'll see if I can bring them up real quick and see if there's time on there for you.
Has anybody viewed them as input on,
I'm sorry.
has anybody seen me?
I asked Carrie to look at it, so we did not get it done. So.
Right, to confirm, so this is for initial certification as well as everybody has to take it before recertification, but will that be, every recertification will require to, once again, repeat this?
Good question. And the way I read the statute is it says it is part of their continuing education. So I believe you would need to take it every certification cycle. But I suppose you could interpret differently.
And what is the proposed implementation time for the initial, those who are?
That would be up to you, you know, because yes, that's a good question, because like, obviously we have expirations coming up. And so the statute says that we should adopt something by the end of last year. But yeah, I think you could say starting January certification renewals or whatever. I'm not a big fan of adding stuff within, you know, the next, you know, shorter period, but I think it'd be reasonable to say beginning in 2026 if you're renewing. But that would be something at your discretion.
It doesn't have times next to it, but, I'm gonna guess maybe an hour long each.
It's my understanding from what they were targeting, I believe they were targeting within an hour to 2 for each offering from the preliminary meetings. I just have not taken the course.
As we move toward the pleasure of the commission, we do need to remind that this is a statutory requirement. So probably take actions here. How soon do we need to act on this?
Technically, the law said by the end of the year, but we're already into the first quarter. So we could, if you don't make a motion today, then we would need to do it at our next meeting, I would think.
I guess I would like, I know a lot of people just feel we keep adding more and more requirements. So if they have an hour for each course and then you have to do it every certification cycle, I'd like to go through it myself and kind of see, if we need all 3.
And I'd suggest it should be updated, like this shouldn't go on for 20 years, right? It needs to be updated routinely and ideally new content added. And if there's not new content, then it should be significantly shortened. Kind of feel like people are getting on board with it.
Is it every year, Craig, or is it every,
It'd be,
what did the law say?
it says as part of their continuing education cycle. They initially had asked for every year and we pushed back and said, no, not every year. But they did want it for every continuing education cycle.
It
So
does
it
go
was good.
towards their continuing education, so,
Yeah.
you know, it would help fill those hours.
But I think that's a good point that we'll need to make sure we update it so it's not just. But it is a law, so I think we unfortunately have to, you know, do it as part of the continuing education cycle.
State that in a lot of cases, sometimes when we have the mandatory requirements for education, you sometimes sit back and look at them and say, how does this apply to me and my geography and my workforce and my people that I deal with? I will say specifically with this one, that just the provider agencies that I speak to, this particular topic continues to grow. It doesn't seem to be receding. Normally, I'm not fond of educational mandates. On this one, I'm more neutral to supporting it. Just because I see the continued numbers continue to grow. I can't help but think a little bit better education on the front end.
And a little bit of background, we actually, when the bill came out, we were speaking with the bill author and she is coming from a good place. Originally only required law enforcement, and then someone said, well, law enforcement has to do it. Why doesn't fire and EMS? We had actually pushed and we were wanting to see like a funded mechanism to offer classes and provide, we're like, if you're dealing with mental health, you don't need another online requirement. We need actual resources. And unfortunately, it ended up with another online requirement. So, well, it actually doesn't say online, but it'd be costly to do in person for everyone.
We just looked at the people that have taken it and it looked like about the average completion time was about 30 minutes.
For selling each one.
Yeah.
Can you clarify one more time? Fire has already approved this and required it?
Yes.
This content?
Yes, through their, like I said, their structure's a little different, but yes, these are the 3 approved programs that they have in the fire service to comply with the law.
And it's produced by the Indiana Fire and Public Safety Academy. So that's who kind of produced the slides.
I'd be on board with moving forward with approving this. And willing to make a motion toward that. So we would have to come up with timelines of requirements. So what's reasonable for new certifications to have it completed by? To our educators.
I would suggest for the initial candidates, we not implement this until January 1 of 26.
So it needs to be completed by then.
Anyone going after a certification after that date would have to have it, yes.
I just like to say that I'd like to see it certified. From just the EMS ground provider perspective, I think it's important enough that we
My concern is, the state mandates that all class syllabuses be presented 30 days prior to the start of class. And we have many classes already on the books for the summer and fall semesters.
Something we have done is I think with other items, we have said for all classes approved and starting after a date. So if you were approved beforehand, you're kind of grandfathered in and you don't have to go back. That's just the option that's out there.
To do it based on the approval date of the class as opposed to the request for certification of the individual. And then, so that date could be July 1.
That would be out of 30 days. There are programs, so yeah, you would avoid that problem. There are organizations that plan for a whole year, so they may have already applied, but again, they wouldn't be applying and approving. They did, so it'd be voluntary for them technically.
Would that cause issues with certification, knowing which class they were in?
That's more for the training institution. I don't know that it would for ours, because we could look at once the new class was started, making sure we flagged it as needing the compliance.
These will be tracked along on CADIS.
I believe that would be the plan, yes. And so, and I also, the other question I would have, and maybe you're leaving it to our discretion, if they are on the fire service and they took it through their fire department, in my mind, as long as we have it in a CADIS, they've met that requirement. It's just the requirement that they take it.
So then a recertification date, everyone recertifying from January 1, 2026 forward.
I sort of feel like that's, not quite, but close to 9 months out. I feel like that's kind of reasonable notice for, a shorter training.
It'll be a lot to get the communication out to everyone, to remind them that they have to do it right. I mean, they're a great mechanism for them to even that, or is it after they submit theirs, then you're like, oh, tomorrow's your deadline
We're
and.
adding it to a newsletter. I'm gonna put it in the PI, district forums that will be coming up, this summer into the fall. And then also, PI quarterly updates as well too. So we can start disseminating that way as well too.
Illness people, right? And then there will be people who make it the last day and haven't done it, and now you have until tomorrow to.
And I'm sure PIO will send a update on this.
Yeah, we've also got a new feature in Acavis that when you log in, we will now have a publication across the top. You can start adding different things to it. Oh, like that. Are we okay with recertifications by January 1 and classes approved after July 1?
Staff is satisfied with that.
Okay, I'll make that as the formal motion.
We have a second.
Awesome. Clarification, so we're talking about new certifications, but what about certs? That will also be January. Okay.
Well, the recertification will be
So that would
January
be
1
January.
and the new classes would be July 1.
July, yeah.
And that's based on when the class is approved, not when they finish the class and apply for certification.
Any further discussion? Roll call vote.
Matt Shady,
Aye.
Darren Hoggett,
Aye.
Mark Hutchinson,
Aye.
Lee Turbin,
Aye.
Jerry Carter.
Aye.
John Zortman,
Aye.
Dr. Brown,
Aye.
Matthew McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Roger Knopf,
Aye.
Lori Bailey,
Aye.
and Jonathan Witham.
Yeah.
Process in place for that.
Thank you.
Next up, EMS privileges for advanced practice providers, Commissioner Wong.
Thank you, Mr. Chairman. So with the attention of the commission, I'm going to suggest a modest proposal. You should receive this in your packet for me today. But looking at the role of advanced practice providers in Indiana EMS, just for full transparency, I am the state chapter secretary for NAEMSP. And as of last month, I'm the vice chair of the NAEMSP Advanced Practice in EMS Committee. And it's from that committee that this original idea was proposed, and I use that as a template for the product in front of you. And basically, it's looking at the Indiana EMS Commission, the state of Indiana, allowing and approving for the use of advanced practice providers, whether that be a nurse practitioner or a physician assistant, to play both a clinical and administrative role in EMS. From a clinical standpoint, it could be involved with many things such as actual 911 response, doing telehealth as part of an EMS response, additional staffing on advanced critical care and facility transfers, as well as mobile integrated health application, and doing actual treatment in the home and hopefully avoiding EMS transport. From an administrative standpoint, they could also provide clinical oversight with the understanding that EMS in Indiana will always be a physician-led organization. An APP might be able to assist the physician, but always be a physician-led product. Participating in performance improvement, frequent user programs to, again, tie in with mobile integrated health, alternative destination and transportation, doing research and training. Some of the basic recommendations and ideal qualities for an advanced practice provider in EMS in Indiana would obviously be, number one, a current and active unfettered license as an advanced practice provider, whether it be a PA or an NP. In the handout, you'll notice that there are some qualifications for the NP because nurse practitioners now have what's called the population-based definition or consensus model, as opposed to a PA, which is more of a global general certification and license. The thing I would prefer is that the advanced practice provider be a current EMS licensed individual, preferably at the paramedic level, but any level will be okay because their advanced practice license would cover any kind of procedures. And then from a non-clinical standpoint, having good knowledge of EMS standards and practice, emergency medicine care and techniques, critical care techniques. And then the final consideration is, would there be a possibility of having that person represented as a chair of the commission? So again, this is just a modest proposal I present today for us to, going forward, consider how to best utilize and approve and license advanced practice providers in Indiana EMS. Thank you for your time.
One of the things that really strikes me is I can see, especially in larger systems where an APP and administrative capacity to assist a medical director and do a lot of things such as analysis of complex calls for auditing, process development, protocols, a variety of different things there. I think the application of the clinical is one that we have to, for example, this one more question for possibly Jonathan is, would it require a legislative change? Like, let's say we were using an APP instead of a paramedic in the back of the truck. Like, you know, have to have a little bit of a legal review there to see what that is. I guess the question is, where do we think we can go with this?
I would, if I may add one thing too. So one, I think you're correct that where the rules address the requirements for a transporting ambulance, that's what gets people paid, to be honest, for both insurance and FSSA. And so we would have to make sure they met that definition or amend that definition. That would probably be the biggest hindrance. We do get questions about medical direction, and we have had some ask, and they wanted to know, can we use an APP for our medical direction? No, the statute's clear, it has to be a physician, but we have said, the physician determines the structure, and we believe they could make either an assistant or just call them an APP. They can be an associate medical director. They have a lot of options that they can do under that. And that is where we have intersected with it the most currently.
And that's why I did emphasize that it is a physician-led process.
If I may, I'm supportive of this in a couple areas. Number one, I think at the individual level, any workforce that doesn't have varied career opportunities, you're going to stagnate, you're going to lose people. This is another area that our providers could, have some career development and things like that. So I think there could be some great benefits in retention as well as job satisfaction. And then at the overall systems level, I do think as we're moving to different models and looking at alternative destination and things like that, I think that's an excellent role that model could play. So I think from both those aspects, it's certainly an interesting idea.
Commission.
Just another clarifying question. So the term APP includes some other, like CNMs and gosh, I think there is some mental health. There's things that falls under APP.
Yes, that's professional majors. It would be physician assistant or nurse practitioner, not CNS, not a midwife, not a certified registered nurse anesthetist. So it's detailed further in the handout, but ideally for an EMS role, since nurse practitioners work on this consensus model, it's a population base. So ideally, the base certification would be a family nurse practitioner. So they see all ages, as opposed to an acute care nurse practitioner, which sees 13 and up. So that would be able to see a child in that advanced practice role. But the family nurse practitioner does not have the critical care background or training. So you could either have the person be a family nurse practitioner, FNP, with either an older person who's been certified for a while as an acute care nurse practitioner, or the more modern version is the adult geriatric acute care nurse practitioner, and or a what's called a emergency nurse practitioner, which you have to be an FNP first to advance to the emergency nurse practitioner. But again, that covers all features. Okay. So there are options. I guess from someone who is working truly as a nurse practitioner, not a clinical nurse practitioner, not a midwife, and not a registered nurse.
Big one.
Andrew, there's an online question. It says, would it affect the medical malpractice insurance?
That I don't know.
Don't know.
So I'm just thinking through this, so to clarify, we've got, for this commission, we would be really only approving, and that would probably take legislation, I think. Proving whether or not you would have APPs working on an ambulance. Essentially to replace probably a paramedic, I would think, generally speaking, right? I mean, that's one option.
It's one option, but more ideally, like some communities in the United States, California especially, the APP responds independently of the 911 truck, like in the chase truck. Or they do a telehealth type of visit with the medics on scene, right, to help guide decision making about treatment on scene and release, or alternative destination, or they actually need to go to the care. So it would not necessarily have to be a replacement of someone on the 911 response vehicle, but it could be a supplement, either on scene separately or a virtual, right, consultation.
Just thinking through this, so, which I think is fantastic, and where there's some amazing number of scenarios that telehealth or on the scene stuff, responding even by yourself sort of thing. So the question is, can that be currently done without legislation and EMS? In other words, you get a call, a dispatch center says, oh, grandma has a fever. She just wants to know what's wrong with her. Can a nurse practitioner just go to the scene? And is there a system that works through without even having to have legislation and EMS commission and Homeland Security oversight? Or would that, in other words, does it require us to manage that or to supervise that?
I think you make an argument both ways. One, you're in charge of your EMS division. Saying, I'm going to hire a PA to be available as a co-director or a 911 responder or an MIH responder. And I'm hiring them, and it's my responsibility, my liability, and I'm paying them, et cetera. Versus, do we need to take it to a legislative level? So I think we make arguments for both ways.
I can see in some cases that being the perfect place to make it. So. It's like the bottom. Dr. Kidd,
So, and I think it has great potential, and I definitely want to consider the things I think Commissioner Mullen for bringing them. I'm not sure that it's pressing in my mind, like people are beating down the door to do it right now. I wonder if we would be better to look at it, because the implications would be in Article 1, which would be our definitions when we look at medical director, and we could look at adding, APP to there. And then Article 1 and 2 both have transport provisions, the crew components and such. Right. And I wonder if that would be a good time to look at it when we do those, because today we're going to look at certs and education, which I don't see how it fits under there. But I think it might be good if there's not a rush to keep it in the back of our mind as we make the decision. Because I do agree, I think a medical director can, under create certain response and oversight with their blessing as if they wish. I think it's a good question. They always want to check with their insurer and make sure that the malpractice is covered. That would be my suggestion, would be before we look hard for, can we do it when we do the other articles of the rules?
And again, like you said, there is no rush to this. It's something that I think is coming to fruition. And I think we can be, kind of ahead of the curve for a lot of states in going forward is first. In California does it, Texas does it, I think Arizona does it to some degree. But I think it is an opportunity. Someone has been a medic for a while, they want back to school, become a PA, don't want to stay involved in the EMS. So it's just further education, further workforce opportunities, even those people within our system.
Well, my understanding is that the nurse practitioner workforce is sort of saturated at this
Extremely.
point.
And
So
unfortunately, and I'm not speaking as a commissioner for the next few seconds, unfortunately inundated with what I feel are poorly prepared for evacuation. So I would hope that the medical director would choose quality people. Back to the chairman.
Does that seem like a acceptable pathway to include that in our regulation for second? So I didn't want to make that motion. So moved. Second.
I'm sorry, I say that again, I didn't hear so well.
Director Kenny had suggested that we make that part, looking at the certification section today, we have the other sections on the rewrite that we're coming into. If we just include that in the section 1 and 2 rewrite, that we attempt to address it in those areas.
Yeah, I'm fine with attempting to address it. I think there may be more things, you know, like the reimbursement stuff that we just need to make sure that we've got a good handle on it. It's kind of hard to think about how, you know, in 1,000 different ways we would do this. It would be easier to think about this in one way initially, how we would use it. So like if we had somebody that wanted to do a pilot program or a model or something like that, and sort of like we didn't build MIH programs overnight, we kind of built them one at a time, trying to figure out how to make it work with the rules, but just worried that once you put it in the code, it's there for until I die, right?
I'm just thinking is, one of the thoughts I had while he was saying that is, because face it, he's the guy that's gonna start us off on the initial draft on any of these. When he gets a question, he has the resources within IDHS staff to get the questions answered as it goes, and then the office will bring it back to us.
And I do think as I review and I'm like, oh, I think this is an area that I can reach out to Commissioner Bowman and be like, hey, how can we incorporate it in this language? So I think it's very workable idea.
I fully support future investigation.
And like I did previously with the, yes, nurse medic thing, I'm happy to participate in the rewrite language. Whatever you needed to call that.
We have a motion and a second on the table. Any further discussion?
Matt Shady,
Aye.
Darren Hoggett,
Aye.
Patrick Hutchison,
Aye.
Lee Turpin.
Aye.
Jerry Carter,
Aye.
John Zartman,
Aye.
Dr. Brown,
Hi,
Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Dr. Knoppett,
Aye.
Lori Maley,
hi.
Jonathan Whitten.
Thank you.
This next section, number 4 under new business, is gonna be a little bit probably lengthy, so we're gonna take a very quick 7 to 10 minute break, and we'll come back in just a few minutes.
Hey, Craig, it doesn't have to be involved. We got a question. It says does that training, the medical or mental health training need to be done annually? Or is it going to be, like you said, every research cycle? Because they've got on here that they shared like a screenshot. It says annually and report to DHS.
Part of the research cycle, but we'll be messaging the actual requirement.
Okay, all right.
So we'll see what that.
I'd love to.
Yeah.
Yes.
Okay, we are returning to session here. And we're also going to make a slight agenda modification. Dr. Yates will have to leave for a pretty important commitment here, so we're going to move the medical director's report to now, and then we'll continue with number 4 and do this after that.
I was gonna come up here because I do have a few slides for part of this, but real quick on a couple other updates, and I'll be brief because I know we have a long agenda. Greg, I think you're getting you there. A couple of things going on. Number one, I know a lot of our services have partners with your local health departments. Their funding is up for review as well, so I highly encourage everybody to be reaching out to your local legislators and representatives and things, and also strengthening those partnerships, because I think those have been very valuable for a lot of our different services, both through MIH and other initiatives and things like that. And when you're advocating for funding, it's always a good idea to hear it from another voice besides who's actually up for it. So I think that's a great way to support and help our causes on the other side of things. I did want to, and this is a whole discussion on its own, so I don't expect any type of consensus or resolution or anything like that, but I did want to bring up having a lot more discussions and hearing from different parts of the state on diversion. And I do think, both in terms of increased frequency and some lack of transparency and reporting that as well. And it's become so ubiquitous that I do think it's something that we probably need to look at in a more in-depth of things. There was a great presentation made to our NAMSP group, and I know the Indiana ACEP's been approached as well. So I do think that's something that's going to keep being a topic of discussion. And I think it's actually tabled to be part of our interfacility transfer summit in May as well. So just really more for your visibility that it's out there and maybe start thinking about some potential solutions and things like that. My recommendation would be to, enhance our data collection, so we know exactly, more concrete how often this is happening, what the effects are and things like that. Also, and then look at maybe some specific areas, post-procedural patients. I think those will obviously need to go back to the facility where they had their procedure, readmissions, things like that. So maybe looking at special populations. Obviously need to do that in coordination with a lot of our services, with the hospital association, and they've been at the table to this. This isn't something that's unexpectedly being dropped in their lap. So I do think there'll be some more discussion there. So I hope there's any thoughts or concerns on that. All right. Otherwise, let's get a quick update on the rapid. So the rapid interfacility transfer pilot that we had, just to give you a quick report. So to refresh you, this is where we took 2 areas of the state, pooled together some critical access facilities, and put out for bid coverage of that, where they would, essentially let those facilities work together instead of just having one service providing care coverage for one facility. We pulled it into the regional model there. We did get a $0 bid for that when we put it out there for bid, which did pose some challenges. And so we kind of came to the mutual agreement with the service that we would do a 3-month pilot period. So basically what that looked like was 2 trucks for a 3-month pilot period, north central part of the state, southeast part of the state. We actually did a pretty extensive marketing campaign contacting the facilities directly. That gave a one-touch number, kind of easy number to remember to call and things like that. Engage hospital leadership of these facilities and things along those lines as well. On the results, I do have a list, and I'm sorry, I'll get that out to you. But basically, the utilization was somewhat disappointing. We only got about 1 transport a day on average from this pilot program, which was interesting. And some of the ones that were kind of the most vocal on needing that assistance didn't utilize it in that scenario. We actually had one facility that had a mechanical issue with one of their trucks, and that was our main utilizer in this pilot like that. And I said Southeast with no utilization, not entirely true. I think there were a couple when we finally dove deeper in the numbers, a couple of utilizations, but not very many. Almost all of them came from the north central part of the state. And it kind of gradually decreased over time on the utilization as well as some of the different facilities came up with their own solutions. We actually reached out to the hospitals in the area and said, you know, hey, what do you think about this? What's your needs and things like that? So we kind of summarized what the different needs look like. Some places said we're fine. A lot of places, it seemed like a general theme of we have our own process, but when that breaks down, we'd love to utilize you. And I thought that was interesting. So Southeast really had very similar responses. So that's the next one. You go on to the next one after that. It was interesting. So we did a financial review. That was one of the parts of this is to have open books. And I thought it was interesting that bottom line, I think, is the take home really only needed to run about 4 times a day to be financially sustainable. So I do think there's a model out there where we could put something together like this, you know, given the right parameters and things like that. So I thought that was an interesting analysis there. Some of the weak points, the bid process was a challenge for multiple reasons. Obviously, the $0 bid was a little bit of a curveball because we had sustainability concerns. Even though we did a pretty aggressive marketing campaign, I did hear back from a lot of facilities. If we would have just known more about it and things like that, we would have utilized it. It's very challenging to get education out there, though, with shift turnovers and, you know, a lot of, you know, travel staff and locums and things like that to get education to stick. Geographic flexibility. We picked those 2 areas because they were the farthest from our trauma centers. But that doesn't always mean that they need the most help. To be honest, some of those have very smooth processes. And then we had trouble consisting staffing after hours. You know, the 8 to 5 transfers seemed to be pretty easy to come up with. The overnight ones and weekends were a challenge. And that's probably when a lot of our facilities need the most help. So we're going into that. So what kind of our takeaways from that? Many hospitals, again, just from the surveys and just what we saw, a lot of places have a relatively smooth primary interfacility transfer process. You know, they use this service to go to this facility. You know, 90+% of the time that works just fine. The problem is there's not a lot of redundancy. There's not a lot of plan B, plan C when that breaks down, is what we've noticed. And minimal surge capacity. You know, I think everybody thinks when there's 4 IFTs that they come out every 6 hours, nice and regularly. And we all know that all 4 of those will come out in a 15 or 20 minute window sometimes. And, you know, so that's when I think having some sort of broader backup system could really benefit our areas. Need, you know, waxes and wanes. Again, with sustainability is challenging, but attainable. I don't think 4 runs a day is a crazy high watermark to make a program like this sustainable. And then I put recency attribution bias, maybe contributors there. You know, a lot of facilities that are like, this is a nightmare. We can't get our transfers out. May have been just a few smaller sentinel events versus a consistent problem, you know, that really became a challenge for them. So that's kind of some of the things we're looking at is deciding, you know, where we're going to go next with this kind of program, whether that be, you know, changing the parameters of coverage location, looking at a regional coordinating center model, a strike team model where, you know, if someplace has some sort of acute breakdown in their ability, you know, being able to plug that gap, leveling transfers to where, you know, we change the different acuity levels of when our transfers go out. Obviously, our time dependent conditions and our highest ones will need to go out, you know, with essentially the same level of acuity as a 911 call. Some of our others that are mainly just capacity issues or don't have a certain specialty, you know, those can probably have a little lower priority. Still need to get where they need to go, but doesn't have the same level of urgency there. So that's it. So the main thing is just kind of assessing that, seeing what that data told us, and deciding where to move next with this task force. So that's where we're at. Any questions on that? Any questions, comments on anything? I appreciate it. Thank you guys for letting me jump the agenda. I apologize.
Very much. Now move on to the initial discussion of Article 4, certifications in education, and we'll identify some director.
My voice issues are catching up. So with the rulemaking, why we're here today. So we, back And then ironically, we had a memory from 6 years ago where we finally finished our review of Article 1, 2, and 4. We had 4 meetings, we had 2 8-hour meetings, and we dissected and went through everything. COVID and rulemaking challenges halted it in 2020, and then we have not taken it up again due to looking at the fiscal analysis and otherwise.
And then ironic that that was 6 years ago today.
So here we are 6 years later, and so we have a draft and I started to say dust off, but I refer to that draft and I update it as we do new things. And I say, we're gonna need this when we update. So it wasn't that hard, but the reason why we're looking at Article 4 is because one, it is the least costly. It is individual certs, it is training institutions, primary instructors. But there were some key components, and then we also did have in the rulemaking that added for the requirement to do criminal background checks. Inadvertently, part of the sections that we added those to, we included the top section, and legislative services thought that meant we didn't want anything after that line. And so they nixed those, and those have important provisions in them. So we need to get those back in, but I said rulemaking is now a chore. It's a little bit challenging, so if we're gonna do those, can we take a look at Article 4 as a whole and see if we can fix those issues, but also add in like the responder well-being and get us going again. So that's where we are, and when we discussed with Council Sean here and then General Counsel Justin, the idea was, let's do a preliminary meeting where we can go through it. If you have comments or feedback, that's good. Then we will come back in May potentially for a consideration of the draft rule, where that way we can make sure. Previously, our stakeholder groups, the EMS Association, the Fire Chiefs Association, Professional Firefighters Union, they were supportive of it. So we want to make sure they're still supportive as well. And that gives us time to do that. So today is an overview, and then it also allows, if you have feedback on things, and I know like Commissioner McCullough had questioned, how did this end up in there, and may want to discuss it, and that's perfectly fine. So the highlights of this rulemaking is it adopts things from 2019. Before that, it is actually 2012 was the last major update that we had. So we're a decade away from amending our rules significantly. It does add a code of conduct. It adds minimum standards of performance for a training institution. Right now, we do work with them. We kind of prod them. But honestly, unless they don't meet the minimum requirements or procedurally they don't follow something, we don't have a lot of discretion, and it's difficult to encourage them even if they are poor performing. I don't think we have poor performing ones on the radar, because that would be the next question. Oh, well, they're gunning for these. That is not the case. We want tools to work with them and approach them to bring them up to higher performing. And right now we have no bark behind or no bite behind our bark. It does adopt essential job functions for EMS as it relates to education. That is a legal concept. If you have essential job functions, then you do not have to do reasonable accommodations. And so that gets into the issue of is there a difference between someone training in a program and whether they could truly be functioning as an EMT or a paramedic in the field. And that's a disparity that this would tighten up a little bit on. It does add the EBOC certs. They're currently policy, but no rules. That makes the general counsel and myself nervous that we issue certs without an actual rule. That would fix that. It does update continuing education requirements to the national core competency, which is national registry model, which would allow for, and this is a big request from those certified, would allow people, if they're national registry, that would meet the national component, and they would only need to report state and local to us. So like the audit reviews and things Indiana required. And a lot of people have asked for that. Why do I have to track it in two different systems? This would eliminate at least where there's duplication. They would still have Indiana requirements, but it would not be that extensive. So those are the highlights that we have. Kind of the timeline that we're looking at is draft presentation for comments, recommendations. And then we will take this back, and now that we have a Secretary of Public Health, the governor's office has said, we will not consider signing off on rules till the secretaries have reviewed it and are comfortable. And so Justin Goodell, the general counsel, will be coordinating with her. But he wants a rough idea of what the draft's gonna look like, so he can approach her and say, here are the elements, and be able to answer questions. Then hopefully at a future EMS commission meeting that we would consider adopting a draft version. That version then gets approved by OMB or reviewed and hopefully approved. And then there's a public comment hearing period. Then it comes back to the EMS commission and they can incorporate or ignore the comments, but we do have to address the comments that are out there. So that's kind of the process. So it's going to be an overnight. And the general counsel wanted me to advise us. He and our counsel, Sean, have been looking at the rulemaking. One, we got a new administration, so we're figuring out all the hurdles. But number two, there are some legislation pending that could change it even. And so it's a constantly fluid item. And so I don't want to raise anticipation that we absolutely are changing rules, but we do want to try to push the process where we can. If any questions thus far? Switch my slides and I will be doing. Nice, it's on TV, so I can see that we're actually transmitting. So the commissioners were sent this. We have not posted it. We do get a question online, Stan. These are not posted because a lot of times when even though I have it marked as proposed, we do see them come back and people are like, oh, I'm doing this because it was part of the new rules. It's like those were never approved, so we're very cautious about giving the wrong opinion out there of these items. The first item that we have, the first big item is adding Rule 1.5, which would be a code of ethics. Indiana, we do not have one. We borrowed the National Association of EMTs has one that we just kind of accept. When this was created, I'm just going to be honest, I created this. I did a lot of research. I looked at NAEMT, other medical professions, some of the Indiana Code of Ethics, and that's how we came up with this. I think the only difference is the EMS compact that we are in, and I know that I'm the chairperson of that. They've adopted a code of ethics for the compact, and states can use that. We did look at them. We believe they're comparable, but when I reviewed it with my staff, our preference was to keep the version that we initially approved, that is the one in front of you. So I'm not going to read all those and risk my voice, but I'm open to any questions as far as the code of ethics. It does indicate on the last provision, if there's questions, the ethics rules listed in this section are enforceable and may be used to form the basis of disciplinary sections under the Indiana Code. And so that is, we get a lot of gray areas where we're like, we do not like this conduct and this should not be the way we do EMS, but we cannot do anything under the current rules because it doesn't violate any rule. And that's what kind of informed me when we were doing these. When I wrote this, I still legal, we were looking at, certain misconduct that slipped through. And that's what formed the basis of the idea of the code of ethics. The final thought I have on the code of ethics is Indiana EMS 2025 did recommendations, and I informed them that we did not, and that was one of the easiest considerations. And the recommendations that they approved is that yes, EMS should have its own code of ethics. if we're gonna be a professional. Any questions on the code of ethics?
I just have a comment to mirror what you said. I believe there has to be a, even above regulation, there has to be an ethical compass. And I think that this gives us something back on anything else that we do. We can come back to this and say, this is the baseline umbrella and everything else falls under.
And I think I can see it being a good education piece, when you're doing EMS education or you're doing continuing ed, think about these things as you are doing it. Okay, next down, training institutions. I will probably go through, so they are broke down into, the article has different rules, and the rules are kind of like section subdividers. So the first one is training institution. So you can ask a question if you come across, but I'll probably go through all of the training institution, and if no one asks a question, then I will pause and say any discussion or question on training institutions. So we do have, on training institution, we cleaned up a little bit on the application. And we did indicate that for the application, we need to know the person in charge of day-to-day operations. And that the person, the training institution official, should be someone that emergency services certification or licensure at the highest level for the training institution. So that avoids a situation where, and we aren't familiar with a lot that have done this, or I don't know that it retroactively applies, but could you have a training institution where an EMT is responsible for a paramedic program? And can they really sign off if they don't understand those requirements? And so that was important to work in. It does, section B does indicate that if we feel that there is a basis for a denial, we can actually deny. And the way that works is we would have to do an administrative order saying we deny it, and it would be subject to standard appeals. So there is a due process there. And typically, right now, we have not had much of a challenge. We have had some that we say, you either need a waiver or you don't qualify because of this. This would make it more clear that the process by which we should be denying them, which is through an administrative order. When you move on to 422, we do on the primary instructors, we added a couple provisions, and this was from the first draft that we did of these, in that we do think we need to document there needs to be need for the mentorship, and we have that program, sometimes called the internship. The rules call it mentorship. We have that process, but it's not in the rule. So this catches it up and puts it in the rule. When you get down to policies, there is a requirement for reasonable accommodations. And with the reasonable accommodations, this gets into the essential job functions. And that is, it's a combination, you have G above, and then 14A is kind of some of the accommodation. But essentially what it says is training institutions would have to clarify, they have to have an ADA policy now. That they would have to clarify what are the reasonable accommodations that they would give. And we vetted this with the education groups. They are not allowed additional time for the psychomotor exam, skills evaluations, due to the fact those are time sensitive. Two, they should not be given unlimited time, but they can be allowed up to 1.5 times of the allotted testing time if they can demonstrate that they have, which would be up to training institution, but typically you have to have a medical authorization that says there is an actual medical need for them to have that additional time. And then number 3, that they should not be allowed to have the cognitive or written exams read to them. And the reason being is that we have several times in the new rule, they need to be able to speak and read the English language fluently in order to be able to do response.
I have a question.
Yes,
Does that pretty much mirror the registry? I believe it's,
I believe it is close to what they do, yes.
we've seen that disparity before where we've had the accommodations and then the student is extremely upset with registry, those being in the same accommodations.
What I think it does is it trickles down to, because I think there are training institutions that might have an EMR and they read the EMR exams to them, and then they take the state exam, where like, no, you have to take it through a CADIS and you're alone. They're like, but no, we want to read it, and then the student's in for kind of a shell shock. So I think it's important to hold them to that same standard so that it's the same one they test, whether it's us or the registry. The essential job functions down here, these are important because they kind of say that you don't modify these with reasonable accommodations. One, they need ability to read and write the English language at the 8th grade comprehension. That is something that can be tested for and is readily accessible, particularly at the high school level. And so the training institutions can do that. There would be a cost, and we'll have to factor that for people in the adult education if they need to evaluate that. There is the expected ability to perform all the psychomotor certification skills independently within the timeframes approved for each skill. And that is an important one because you get that question. And I will often get it, well, the person's in a wheelchair, they can't do compressions, you know, can they be certified? And unfortunately, no is what the rule would say. It's because they have to be able to perform those essential skills, because that's the expectation of the public when they call an EMT, advanced EMR, EMT, advanced EMT, or a paramedic. The criminal background check, I did review this. This was in there. We have a policy. I am recommending leaving it in the rules because I think it's important. They will have to do one for us now, as you know. And we will come up with a policy that allows them to maybe transfer depending on how long, so they don't have to do it twice. But we think in an educational setting, they need to have that criminal background check before they are interacting with patients in clinical rotations, so that way we're not exposing the public to risk. So we think this is important as a public safety one to have. Same thing for drug and alcohol screening, require that before a clinical setting. And then the training institutions do have to adopt standards for how they deal with it. And I've had mixed reviews. Some training institutions would prefer the commission to say, this is what happens. Other ones like the flexibility, but you could get a little bit of inconsistencies. There could be some that are zero tolerance. Most that I've seen give them an opportunity for like either a rehabilitation with monitoring and things of that nature. But what our requirement, if we don't change it, would be that they would have to adopt the standards, and it would be on the training institution to say what happens when there is a negative screen. Minimum requirements for training on the EMR. These were added just because we spell out EMT and it wasn't clear in there. But there is a little bit of a change in that it is right now, the EMR can be taught by independent primary instructors. And so sometimes we have had challenges where the instructor is not meeting their duties. Yes, we can sanction the instructor, but it's very hard for us to monitor them when they are unaffiliated. What this would require is like EMT and above, that it has to have a training institution. And so it essentially would halt freelancing for EMS instructors at the EMR level. But when we discussed it 6 years ago, we determined that we felt for the safety and the integrity that it was important to have the check and balance of a training institution. There is a chance that could increase the cost to the EMR courses, so just noting visibility. Training institution have the responsibility to produce qualified candidates. That includes they have to monitor the effectiveness of all their instructors. They have to produce successful candidates. and then there's failure criteria. They have less than 50% of the candidates passing the approved exam within 3 attempts. This was, if you look at the language, the reason this was picked is we understand, particularly in high schools, sometimes you get students that audit the program. They don't ever intend to be certified. So the question is, do we have to make them take the registry? And does that count against us? It does not. It says the students that are testing is what is going to work for the training institution. And then they have to have a written policy on remedial education, on the examinations, and how they will then determine their effectiveness. What this does is, on number 18 is if there's a failure at training institution to meet these requirements, then we can implement a performance improvement plan. We might deny future courses at that offering if they are. So for instance, if they're ALS, and there's an issue, we could pause their ALS program, but still allow a BLS program. And ultimately, we could issue disciplinary sanctions under the regular sanction. That can be the fine, suspension, or revocation. And so it puts more teeth into what our ability is to protect the public in terms of training institution. Again, our goal, I hope I never issue a actual written sanction against the training institution. I have issued 2, I believe, but we prefer to work with them and come up with a plan to improve it. I want to go on record as saying that. We could have an action against training institution as ordered by the EMS Commission or a general policy. So if we adopt a policy that, let's say we want to see this new standard implemented and the commission says if the training institution doesn't do it, they're subject to a $500 fine, we would then issue an order subject to commission policy. For training institution requirements, reporting requirements, they have to report adverse action against the training institution to us. Right now, sometimes there could be action by the accrediting body or by the registry that we may or may not hear about. Usually we hear from either of those bodies, but the training institutions are often silent. So if they have an action against training institution, they have to notify us. They also have to notify us if they take action against any of the members that the primary instructors that are working under them. So that we make sure that we have that information. And then it just defines what we need to know when they notify us at the state. So with that, I'll pause because that is one of our bigger sections that we increased kind of the rules and try to improve both quality and protect the public by doing that. So I want to make sure to give the commission time to discuss if there are questions or concerns with any of them.
You want to hear typos or do you just want us to send them? Do you want to hear any typos or do you want us to send them to you
You can
later?
just send those to me, because I have it in my PDF, otherwise I change it while I'm standing. I should have brought up the Word version. Thank you. Yeah, it's good to catch typos. I will say some of the wordsmithing, I warn everyone, particularly those in the public, although we have newer commission members, some of it is the language that is required by legislative services. So sometimes we don't like the word. You're going to see further down, for instance, they changed the reacquire provisions. It's in the reacquire in our terminology means that you are totally expired and you want to come back without having to go through the whole process. Legislative services changed it at some point and they switched it to recertify, which is what everyone does. So it almost looks like there's 2 provisions for recertification. And that's where sometimes it gets frustrating because they get like the word reacquire and it needs to be reacquired because it's a specifically different item.
Got one question.
Yes.
So on looking at the institutional responsibilities on 14, it talks about drug testing.
Yes.
is there gonna be anything if they come from another state that has legalized marijuana or THC and they test? I can see that going on.
So my recommendation, the way I would interpret that right now, you guys are welcome to change it. The way I would argue is it does say they have to test for it would be the requirement, but it does have, says they can adopt written standards. So I would recommend, particularly, I know we have some of our northern people, they might want a provision that says, hey, if you're from Illinois, then, we aren't taking action or whatever you're doing.
Just because it's legal doesn't mean we want to use it, in my opinion.
Yeah. We do differentiate and I say that with our staff, if someone is picked up with a marijuana offense, just for visibility, we don't sanction them unless they are on duty and it's tied to their EMS duties. But yeah, we definitely don't want them to use a substance before working. EMRs, a lot of the EMR, it looks like there's a lot of change here. What happened was it's a little bit older and it is listed as first responders. So we finally, oddly enough, the legislature got it correct. So if you read statute, it says EMR, but if you read the rules, because they're so old, they still say first responder. So it looks like a lot, but really what I did was I mirrored it to the way it's laid out for our other provisions, because a lot of times staff and I have problems finding the EMR provision because it's laid out so differently. And so realistically, there's not a lot of change there. And I would argue the 1.5 is kind of this restructuring the other compliance that is already there. I think the new provisions would be down under B here, the ones I have on the screen. And you're going to see these for all certification levels. And that is number 6, which is a requirement to notify us within 14 days of a arrest or a conviction of criminal offense. I would note that of an arrest is 14 days. And then I added in the language where the statute that is passed by the legislature says within 90 days, they have to notify us of a conviction. And we originally wanted to note both of them within 14 days. I am not recommending it. It's heavily debated at the legislature. I'm recommending that we adhere to that and not try to have a rule that is tighter than the actual legislation. And so, but I think it's fair to ask for the legislature, we asked for notification of an arrest. And their concern was they didn't want people prejudged because they have a right to be innocent. We are requesting to be notified because there may be circumstances, most time we just track tickets, but every now and then if it's serious enough, we'll do an emergency suspension. And so we think it's important to know when they're arrested, so that way we can track that. That's why that requirement was put in there. It's been modified slightly because it includes that new statute. Number 7, there is the responsibility to comply with an investigation. Most people do, but every now and then they're like, butt out, I'm not interested. And if they don't want to answer our questions, well, then that could be challenging for them. Maintain their online portal account. Unfortunately, with legislation, we can do our notifications by email on record. And this reiterates it's their responsibility to keep their record up to date. And so again, you're going to see those 3 provisions of all the cert levels. The forms, there's a lot of language in these, but it's updating to what we're doing. I think the biggest change we had for EMR, and I want to reiterate, I did not change this. This is language from 6 years ago. EMR currently does 20 hours, and 4 of those have to be in cardiopulmonary resuscitation. Our recommendation was that instead they have to produce evidence that they have had certification in cardiopulmonary resuscitation and not an hour requirement. But we did request, while there are psychomotor skills, the request was that EMR have to do those as well as part of their recertification. They currently do not. They only do the 20 hours. And so there'd be a slight change in that the hours would be 16 hours. We'd drop the 4 hours of the cardiopulmonary resuscitation, but they would have to do a CPR certification. So I want to make sure I highlighted that because that is probably the biggest change I think we have for that. The next sections under 2, you're going to see in all the provision. It basically does 2 things, requires the online renewal process, and then B talks about the audit process and their responsibility to participate in an audit. And then C is that, E is that improvement where if they are nationally registered or certified, we do not have very many EMRs, but we do have the other certs. If you're registry certified, each of the categories has a national, a state, and a local. And the national component would be recognized by us if they produce evidence of current national registry card. And so that would be an improvement for them that was requested by the certified person. We did add the late fee is weird when the commission adopted rules, and I apologize now that I think about it, I think it's 2014. 2014, still a decade ago. When we adopted the rules for late fees, it's in 2 of the provisions, but it's not in 2. And so we're just making sure we clarify it applies to all certification levels. The reacquire, the infamous reacquire that's changed in other places in the rules will capture, but it has to be within 4 years of the prior certification date. This is something that we requested. Currently, there is no prohibition. So if I was an EMT or an EMR in this section back in 1992, I could ask to reacquire and take the state written and state practical. If I pass, I'd reacquire. There was concern from staff and the commission agreed at that time. And we indicated that you could only go back 2 cycles before you would need to redo the education. So this would be a restriction on people hopping back into the profession. Most commonly, I do not have statistics to show you. Most commonly, if people do it, it is within 1 to 2 cycles, but every now and then we get someone. I had someone recently that was like 6 years ago and staff's like, are they allowed to do it? I go, under the current thing they are, but we're looking at it for a new rule. There is no inactive status for EMR because it is continuing education. And then we added language for all the levels that the temporary cert expires automatically. Temporary certs, you have to have an affiliation. So if they don't have an affiliation for a temporary while they're getting their cert from another state, it'll just automatically expire. Those are the provisions for EMR. Any questions, discussion? Yes.
Question I had is just. This done in the EMR section, there's a 4-year.
Yes.
It says they have to go and complete 1 cycle at the EMT curriculum level.
Yeah, we need to change that. Okay. Yeah. It was probably copied from that, so. You didn't leave them. Thank you. That's good catch. Questions, discussion? I think some of the others will go quick because they do mirror that process. For EMT, on 441, you see a lot of bold here. That is what was, most of it is what was accidentally dropped when we added the provision Number 4, that's not highlighted right here, submit the criminal background check, then everything below that got done. But there are new provisions, which again are 6, 7, and 8, which we added to all the certifications, which would be the contact information and comply with investigations, things like that. Application for original certifications, again, cleaning it up. And actually, I'm sorry, it does have the renewal here. We are recommending switching it. This actually changed even over the 6 years, the national model changed the hours and the buckets. And so we may have to look at updating this from time to time. But I will say that there is concern from legislative services when high source. So like it's difficult to say, if the registry changes theirs, Indiana will change ours. They want an independent review each time. And so that's why we use the most current version rather than tying ours to a body outside of Indiana. And so the EMT would be 20-hour certification. The hours are listed there. We would continue to require, if they are affiliated, they would need to do audit review. If they are unaffiliated, they can do general training. Then we address mental health first aid there as well. So, and then there's 10 hours of local, which would be, if they do not establish, would be general continuing education that they would need to do. They'd have to do the written evidence of CPR training, and then they would have to do the mental health first aid program as approved by the convention. Of interest, if we do that, and this is something I'll have to discuss with our council, the way I have it worded there is evidence that they have completed it. So we'd have to compare it to the statute to see if that is a renewing requirement every 2 years, like we discussed earlier. If we adopt the rule, it says evidence, so that kind of implies it could be at any time. But we'll probably have to review that before we approve the final draft. And then we did add in the NHTSA, which was a request of it. We were going to do that traffic incident management training, that we have that. And so that has been added as well. The online certification, the audit, that again is the language bringing it up to what we actually do. And oh, yeah. Okay, so then we do talk about if they hold multiple certifications, the EMT is considered an embedded one. We treat it that way, but basically says if you update the higher certification, you still maintain your EMT, and we update those for you. National Registry recognition, if they have that national component, they would get recognition. They'd still need to do state local component as well as the skills section. To reacquire again would be 4 years, maybe do 1 cycle, which I'm going to check is EMT, which is appropriate in this section, and pass the exams. Reciprocity, we did add, I added, this is new for this cycle, that they have to do the criminal background check. And then when council reviewed this, they pointed out when we were looking at the policy for the NHTSA 10 training, the traffic management, that there's a question on reciprocity, whether we can make that. Right now, we assign them a CADIS courses and everyone does it. No one questions it. But it is because that's part of the base curriculum. This would indicate that they would need to do all the requirements that you require here in Indiana. And that way it's very clear to them if they go to the rule, and they aren't going to be surprised by that. Again, a temporary license would expire if they are not affiliated anymore. The only time we do a temporary is when they're working on their permanent and they have an affiliate that's working with them. So if they lose that affiliate, they don't have a temporary. Unless they could get a new one if they get a new Open to any questions on the EMT. Primary instructor, we do have a few changes here. With primary instructor change, and I know Commissioner McCullough had asked me about this. They have to have 2 years experience in delivery of emergency medical care in a pre-hospital setting. And the recommendation when we did 6 years ago was specifically with an EMS ambulance provider. While we prefer pre-hospital setting, sometimes people have ER experience or other type of experience. And that was a question that we had. And so I don't know if we want to pause. If you have anything further you want to say on that while we're here.
I was just asking, because originally it was just, pre-hospital setting, but adding that, I don't know if that would, see, we've added another year, which I have no issue with that. But when you say specifically with an emergency medical service ambulance provider, so that means you wouldn't have any new PIs. Maybe worked in the field for years, but they never worked on an ambulance, they can't. Which I don't know if working on an ambulance, that's somebody any more than somebody who's working in the community. That's like, I don't know if you're going along with trying to get the workforce up and trying to 2025 report on this kind of hinders some of that. You specifically tie it to that applicable.
That provision was added when we had our mega sessions. And I remember the primary instructor pushed that. That did not come from staff, I don't believe. And the thought was that, which I sort of understand, I'm on the fence personally myself. But the idea was that if you've not done it, can you? And so that was where it was coming.
I only thought it's just the one section on ambulance operations. We're working on it. See it. You can catch up. If they're doing it actually by curriculum, they shouldn't be touching the con. They should be doing some of those things that are unique to ambulance, but that is just one section of the program, you know.
I do think too, the training institutions have discretion there too, you know, and we've been, and that's something Carrie does a great job working with them. The idea is to empower the training institutions. And so if they feel like someone doesn't have that background, then they can be looking at how can they do that. So I think it is an area, if we don't want to include that, we could strike that language. Striking it or not.
I'm gonna strike. I mean, just like most PIs, but granted, this takes a little bit of self-assessment. Most PIs, if they're not comfortable with teaching the subject, they're gonna find a different PI to teach that subject.
Other thoughts, if people are comfortable overall, we won't do a vote because we're not approving it, but it kind of helps me on the draft. I will likely strike it and I'll try to remember to flag it when we do the formal in case anyone really feels like it should be in there. Because yeah, you'll certainly have a say when we get to that. Number 3 of this is that right now we get a affiliation, it's usually an email, but sometimes they sign off. And one of the requests, and I agree 100%, is that we need a commitment that they will supervise and mentor the primary instructor upon successful completion. Because sometimes I think Carrie can address, sometimes we'll get a training institution that says, oh yeah, they can take a PI class, and then they finish, they're like, yeah, we're not doing it. And then the PI's left hanging because they need to wrap up that education. And so we feel this is important to kind of close that gap. And to clarify, primary instructor exam would be within 1 year of the completion of the course. Pass rate is set at 80%, and they have 3 attempts. And that is the Indiana exam that we'll talk about the other exams here in a second. They have to complete that mentorship program and return paperwork. They have to complete a course. This is where I always get a little confused, and it's the steps. So I'll try to explain it so maybe it's clear to you guys. You can substitute the course with the NAMC, National Association EMS Educators, as a level 1 instructor course. That course is excellent. We strongly encourage it. We have looked at maybe some scholarship to let people do it. It's mostly virtual nowadays, but occasionally an in-person offering. It has a test, but its test at the end is kind of like a quiz. And so we're very adamant that we do not want to accept that certification as a direct certification. But if they have the certification that meets the class portion, but they would still take our written test and go through the mentorship then. And that would count as essentially the Indiana course. That's what's covered in this section. When I go down in a bit, you're going to see there is a certification they have at a higher level, which we do accept their certification. But at level 1, it only substitutes for successful course completion. Recertification, 2 years, has that same provisions, that you have to report arrests, things like that. It does have the late fee added for the PIs. We do have a new provision here that adds a few requirements for instructors. It's kind of a mini code of ethics, but we call it shall abide by the professional educator standards, including, and we have a list of A through I there. And with that, those are things that we borrowed from National Association, the EMS Educators position statement. We strongly feel that these are important foundations for PIs. We occasionally do get questions and complaints, and we currently don't have a method to follow up on. And so I think these would be important to include in the rules. They have to notify us of arrests, comply with investigations, that sort of thing. Now, when we move on to, we have an unaffiliated status first. Unaffiliated status is where currently a PI, the moment you're unaffiliated, you really don't hold a PI. It just like vanishes, even if you're in mid-cycle. So sometimes a lot of times you can bounce to another training institution, but sometimes people really struggle to, they need more time, a couple of months. And then usually they're having to apply to reacquire and go through all that. Our recommendation was that there be an inactive period. And this is what we approved 6 years ago. And they would still collect continuing education and such. But they could only do affiliated status through the end of a certification cycle and then not more than a period of 3 years. And so depending on where they fell. So it gives them really 3 years to become affiliated, and then they would not be eligible to renew. And so staff is still supportive. We think this is reasonable, gives them a chance, but we don't think it should be indefinite. But we do think, and like the paramedic unaffiliated is kind of indefinite, that anyone could do for a prolonged period. This would limit it, but would give them an opportunity to find someone. I think the last provision of the PIs is certification based upon reciprocity. These are the categories by which we accept you from other programs. The first one is the NCEE, Nationally Certified EMS Educator. That is through NAMC. And what happens is you become a level 1 after 3 years in teaching so many classes. You do, I think maybe there's even a refresher. Is there a refresher?
I know you have to instruct for at least 2 years.
And then they will, you take a more challenging exam and you pass that exam. So if they come to us with an NCEE, we feel like that's a direct reciprocity as if they held another state license. And so that's pathway number 1 is through NCEE. Pathway number 2 is coming from another state. If we verify they have comparable, they still have to do, all of these still have to take the Indiana exam. I apologize. The NCEE, we did not feel needed to do the Indiana They do have to do the mentorship to learn how we do things in Indiana and all that paperwork, but not the test. But they would, if you are coming from another state, you would also have to do our test and pass within 80% within 3 attempts. The final way that they could do that is if they come from a comparable course of study to the Indiana primary instructor course. And that would be potentially military. And number 4 would include other disciplines that would be, for instance, fire instructor 2, a law enforcement instructor that would allow them to transfer over, recognize that, but they would still need to do the examination, Indiana's PI exam, and the mentorship. That's all for the PIs.
And Craig, I do have a question on the PIs. On the fire side, let's say they're a fire instructor and all that, they want to get their PI, but they've never worked the ambulance. They don't have that EMS component when that, like the 1 year or 2 years. Let's say they've been a firefighter for 20 years, but they've never worked in the EMS field. How would that work out for them?
The requirement would be for the new students for the 2-year period. So if they were coming, they would need to hold.
So they wouldn't need that,
so
even though they've never
not
done
have
EMS.
The way it started.
Interesting.
Do we need to look at changing the fire? I know the fire academy has changed, the fire instructor, the name of that certification. We may want to look to make sure we're using the same language.
If you want to write a note and do that,
Okay.
yeah, I'll make sure. This was the most current when we did it, but it was 6 years
Okay.
ago.
Yeah.
Because it used to be a firefighter 2, 3.
2, 3, yeah.
And now, as I understand it, as long as it's 2, and I think he was in here, but Jeff Quinn was very vocal on that. We got it updated because he knew.
Yeah. That's actually.
The other questions on it? Advanced EMT shouldn't change too much. Oh, yeah, I remember. I think we cut off a few things. The advanced EMT, I tried to do both at once. If you remember, we did the criminal background and we updated the advanced EMT. Well, when they adopted it, they did merge them and somehow they left off the criminal background check. So that would require it for the advanced EMT. It also does, has a few technical corrections there. And the continuing education would go to the national model. The one thing that happened when we got that through, I didn't realize that it changed the national core competencies. So the hours changed slightly, but they don't have as many changes in the language because we just did a rulemaking. I believe in here somewhere, sorry, it's probably tiny print, but it should have the reacquire instead of recertified, which was something that got in there. Any questions on advanced EMT? Closing down here, paramedic. On the paramedic changes, they are very consistent with the others, so it should go pretty quick here. This, the language, this was the language that Commissioner Bowman helped us with in bold. So this, unless he sees something that has changed, it talks about when nurses have the ability to kind of challenge the paramedic examinations and crossover. So we thank him for his work on that.
And just a couple things, since I rewrote this a few years ago, there's a couple things, under number 6A, A list of courses for trauma. The University Nurses Association just this past month came out with a new course called TNAC, Trauma Nurse Advanced Care, which should probably be added to this list. It was not current at the time this was recreated. And then down under, under C, the nurse practitioner, number 5, where it talks about the FNP or ACP, et cetera. We should probably add in the ENP, emergency nurse practitioner, as a certification level as well. Then I think the same thing under number 8, we would need to add the TNAC.
You want to email those?
Email them to, yes, sir. And I'll look through to get in more detail on anything else.
Okay, inactive status, not a lot of changes there. General certification requirements, 493 is again where you see number 5, submit to criminal background check, then inadvertently deleted most of the rest. So a lot of this is just putting it back in. But it did add some new requirements, which start with number 6. So 6, 7, and 8 are the new requirements. And it goes into, they do have to notify us when their affiliation status changes. If they do not have another current ALS affiliation, gives them 48 hours to do that. We mark them as inactive, we send them a letter, and then they have to notify us of an affiliation before they could have an active license. And so does talk about the paramedic includes the EMT, and it does indicate that may operate as an EMT when unable to function as a paramedic. So we do get questions from that, you know, like you volunteer for a fire department, you only have BLS equipment. Am I doing my scope of practice if I'm doing EMT, but I'm also a paramedic? Well, it's whatever is available to you. And so that would clarify for them to give some guidance on that. Application for certification. And the National Registry, we would use for the NCCP requirements for the national component. And then I think there is a new provision on continuing education here. The medic continuing education would go to 60 hours for national component and then 15 hours for state. We have our standard audit review, any state order training. And then 15 hours would cover the local component. So they do have the requirements for the mental health first aid and the NIDS 10th course as well would be added. Certification based upon reciprocity. Not a lot there. Again, they have to do anything else Indiana has to do. So criminal background check, have to do any assigned to CADIS trainings, things of that nature. And then temporary license would expire if they do that. Any questions on paramedic?
I think somebody's just more of a future comment that we need to look at from the perspective of many states have went to the more of the NA industry model of you have this triangle or between the paramedic and the medical director in the state, the provider, you try to figure out who does things. We have these additional layers, volunteers who runs the hospitals, and then a paramedic suddenly becomes not a paramedic when they don't have a provider. We did switch from certification to licensure in the legislature a few years back. But really what that was just a replacement of title, rather than true paramedic licensure. I think at some point, like for example, my Kentucky certification, or a couple other certifications, I don't lose my paramedic when I don't work for a big provider. I think it's something just to keep in mind for the future if we have the opportunity to kind of separate the need to have a provider to be a paramedic. So it's just something I think as time goes on, it'll like tackle.
And we struggle with the words, because yes, when they did that switch from cert to license, at the time, you know, it didn't really give us anything. I struggle a little bit because in the certifications world, a cert is something that you've demonstrated and you get a nice completion, but you might be able to use it, but it doesn't technically authorize you. Once you have an authorizing body that says you can function, then you actually have a license. So like the registry being on their board, it's been very clear because yeah, in Indiana, we get people every now and then, they get their national registry, they're proud of that, and then they don't follow through with Indiana. We find out 2 months later, and we're like, you aren't licensed and your provider can't bill for all the running you were on because you have to be licensed somewhere, you can't be certified. So I think there are confused, but I do understand your point on, it is kind of weird that you go inactive.
And it would save us a process too. I mean, you know, we just been really inactive out back and forth, which is a paradigm.
Emergency medical services vehicle operations. This is adopting the course. We took this, and it basically says that it is the NHTSA course, and that course is now from 1996, so it's old, but it takes the core principles there, and then you have to have a competency driving course. And then the renewal course is significantly less time for that. Where these came from, these are policy. Most of it is the current policy, but I assisted Tony Pagano when he was here, like between 2017 and 18, and we met with the core driving instructors who are quite a devout group, and so we deep dived into that. And so these are all the things that came out from them, for the most part. And I tried to capture it, that these have not changed since we did them 6 years ago. But there would be a certification, you have the same requirements, you have to apply, you have to report things, you have to update your CADAs. Continuing education, there is a couple of different options. They can either redo the whole course. If there's a renewal course that we defined previously, they can do that. Or they can do continuing education related to the curriculum if they have 6 hours. I find it weird because I'm like, can you find 6 hours of driving education? But maybe you can. And if you can, that could be a basis for renewing your EBOC cert. Yes.
For a paramedic who's currently not affiliated with an organization, myself included, so I'm an inactive paramedic in the state of Indiana. Are they required to do the EBOC course? Because we're not driving there.
This requirement, to clarify, does not add a requirement to do EBOC. So typically, if we did a requirement, it would probably be on, and I think we have a provision in Article 1 that we'll have to discuss when we get there in the future. We debated it, but due to the cost and not sure of the full availability, this is an option that people can take. And it is not a requirement on people to do an EBOC. So, but I will use it for a educational purpose. So even though you're an inactive paramedic, you have an embedded EMT, so your EMT is active, so the requirements would hit on your EMT requirement. We do have provisions for instructor certifications that mirror the EBOC as well as our other primary instructor. And they would have to instruct at least 2 EBOC courses. I realize rural areas are a little challenging, but one of the requirements that is in Article 1 draft language was that a organization should at least once a year have an EBOC offering. And so the thought was there should be opportunity to get those. We do have a late application fee as well for that. We do have reciprocity. If we recognize their program from another state, we can validate, then they would be eligible for reciprocity. And finally, if there are sanctions that can be taken against their EBOC certification, as well as if it would apply their underlying as well. And that is the EVOC provisions, but thank you for allowing me to clarify that. There is not, due to cost effectiveness, this is a opportunity for safety and to prove that you are training people. And I would note, when you read the EVOC, it has to be based again on those principles. And I was a strong proponent, because I know in Putnam County, when I was director, we used volunteer firemen's insurance. So we didn't use like a national EVOC or a CBO course. Most courses use the 1996 parameters. So if someone's doing emergency vehicle driving, they probably qualify for this certification, and it becomes a tracking tool for people to make sure that they are fine. Open to questions or comments or discussion on EVOC. If you have feedback between, get a lot of directives, we wrote some notes. If you have other feedback, something doesn't sit right or something, let me know and we will see what we can do. And then I will share if I'm further at amending this. But yeah, thank you everyone for your attention on this.
Moving on to old business, I shut it down. Move on to administrative procedures. Some information only, or?
We have no actions today, and we do have hearing here. We do have a hearing coming up on one of them, which is Troy Louthan. He has a hearing scheduled for April if that goes on. But we don't have anything else. The waiver orders are in your packet for information. Discipline orders, we did have a little bit of a media popular case in northern Indiana that we did take administrative action, and that should be in your packet as well. Nothing further on administrative.
Moving on to staff report, state registry.
All right, data. EMS reporting, you can see that we have dropped below the 90% that we were coming accustomed to. What I found out was some of the providers, some of the new providers either didn't get added so that we weren't counting them, or we've had a lot of providers switching software companies. So we had a gap there of not receiving any data. I've sent stuff out to all the district managers. They're all working with those providers to find out what software they're using. We're getting that into their integration accounts so that we're now receiving data. So next month should be a lot more coming in. Fire reports, we're down to 64% again. A lot of changes of software. We have a lot of new ESO customers that we didn't have. So we've been emailing back and forth with the ESO guy, trying to get those guys into the integration account. So that number should increase as well. The transition to Nearest, although Indiana is on the docket for December for Nearest, because we are in FEMA Region 5, they're going by FEMA region, we're on the docket for December. I found out 2 days ago that I was supposed to have, or Indiana was supposed to have something to Nearest on Monday. So we're going to work very quickly to try to get that done. So that will be, then we can see if there's already departments that have already transitioned or are in that moving forward. But we'll have a lot more communication coming out for that throughout the year. But we are a bit behind on the Nearest is what I found out. So we'll work on that. Is that my only one?
Not good.
Oh, I thought he.
I have it set up. Yeah, your operation network. Yeah, you have slides.
All right. That's it for data, unless you got questions.
I separated. She
Oh,
said
sorry.
it all.
Are any of the departments in Indiana that are doing like a preliminary run with nearest up in the northern end? Or-
Indianapolis Fire Department was the only fire department in Indiana that was doing the pre-run
Okay.
thing. And I don't even know, I haven't been able to log in yet. They're supposed to be sending me that information to be able to log in to see where the department's at, if they did that. But IFD was the only department that was preliminary testing for that. Yep. Operations report? Yep. Okay. Everybody knows that we've been moving to Acatus. Again, the first of the year came around. We had a lot of new fire chiefs, a lot of new people in charge, and they're all calling and saying, well, I need access now. So trying to tell them again, go fill out that agency roster request. I'll send you the permission form to try to get that. So that, of course, with everything else, beginning of the year is always a little bit of slowdown there. So we're working on that. As well as the Acatus permission or the provider organizations going into Acatus. We've gotten through a couple quarters now of doing that. We'll be working on July for people because those will open April 1st. That's going well. They love that they can get in and see that and print that. The one issue that we're still having is on the vehicles. They're going in and adding their vehicle and we don't know that. It's not anything I can stop because Acatus doesn't have a stopgap there that if I give them access to be able to see it and print a cert, they can then also change. So we're still working that to try to make sure that people are still sending in that vehicle application. New EMS district manager for 3 and 6. As you know, Don retired in October last year. So Jamie Thomas is our new district manager for 3 and 6. We've kind of thrown her into the. We've kind of thrown her into the deep end. There's been some challenges in especially District 6, as many know. So I just sent her another complaint yesterday. So, but she's doing very well. And what helps, I think, for her, especially in District 6, is she's paramedic. She's knows a lot of the people in that district anyway. So she's catching on very quickly, and we are glad to have her. The other thing that I did put on the slide was we've got a state exercise coming up in June. That field staff will be participating in. We're in the EOC and at the state fairgrounds. I don't know if any other agencies are participating in that. And then we are also, myself, and I'm going to drag Janie along since she's not done it before, is the Indianapolis Airport will be having their exercise in June as well. So I'm going to bring Jamie along to do some evaluation and whatnot with the EMS side of that. And I think that's it. Any questions? Awesome.
Okay. Certifications and compliance, Cory.
Yeah.
Yeah. This is for the fourth quarter of 2024, since we're not at the end of the fourth quarter for this year. You'll see all of the numbers for current certified have increased. The number that did not renew is, which is good. Over 25,000 providers in Indiana now, up 990 from third quarter of 24. Audits, we did 277, 16 repeat, 5 certifications, honesties, or sanctions were issued. Criminals, we've had 74 that have indicated to us charges. 57 of those were results, sorry, I can't see. 10 have additional information that was requested, and 7 are pending court, so we're tracking those still. Our turnaround time now for certifications is 24 hours or less if their applications are submitted through the week. Submitted on a weekend, the next business day. These are turned around more quickly if all of the ACADIS trainings are completed, specifically the violation statements and posts, that stuff. Currently, until now, there was no ALS application within ACADIS as a web form, so everything would have to be emailed into us or mailed. We did create an ALS initial application for those that have completed the national registry, are applying for reciprocity. They can do that through ACADIS now, so it's a lot quicker for us to issue their paramedic. The portal user agreements, these have been a big talk. Every quarter, these are going to be renewed. You have to go in and renew just like you would a certification or license. Failure to renew those would result in your ACADIS portal being inactive and gone. The other day we ran a report and it was 66,000 that had not been done. This morning we ran a report and it was 15,000.
I would add, and on the ACADIS renewal agreements, the reason those came about is we had extensive open accounts, and particularly on the fire side that don't have expirations. No one knows if they're using them. And so they did these agreements, and the understanding I had was that they would operate tied to your EMS service. That is not the case. Like, I just had my renewal successfully renewed for 2 years. But when Corey and them notified me about it, I went in and I had to look because it was the bottom of all my certs. And sure enough, I had one that was gonna expire. So we're trying to look into, can we change that or not? Is there something we could do differently? But I think it's important to note, the reason it's out there is because it controls the size of the system and prevents inactive accounts. I would also like to pause and commend Corey. You mentioned their turnaround time, doing very good things. And then I try to remember if she came to a meeting or not. Jennifer Sherman is here. She's the other certification, the first line when you call in. Both of them do excellent work, and we're glad to have them on board.
The ACADIS certificate, is it every 2 years then? Is it the same as?
Currently.
But it doesn't correlate with your.
It does not.
Okay. Thank you.
And it's only this first group is why it's so big is 2 years ago when we put it on, when we figured out the issue and we put it on, we put it on to everybody that had a portal account at the time.
At that time.
That's why it's such a big number now. Nowadays, when somebody requests a portal account, it's automatically added now that they get a new one for 2 years. So the rest of the quarters in the next 2 years won't be nearly as big as all of us that have been around for a while and have a portal account for a while.
Thank you.
Game on, Corey. Robin and I are gonna start adding graphics to our PowerPoint. So be prepared next time. Game on.
Yes.
So, just a quick update, National Registry has announced that the new EMR EMT exam is gonna launch on April 7th. The students have been getting some sample questions in the past. They aren't getting the scenario-based questions like they are at the advanced level, but they will have some build list, drag and drop options, checkbox. And instructors can go to the National Registry website and share that with their students. The students can actually look at some of those sample questions to get an idea of how the exam is going to be. They also have divided up the domains into a little bit different categories, a little bit hard to see on there, but that's also listed on the National Registry website. Exam fees will stay the same as they were in 2024 this year. EMR is 88 and the EMT exam's 104. All right, so real quick, we all kind of realized that we talked a little bit today about that TIM training, that traffic incident management. The good news is our friend Danny Matlock from NDOT has been working really hard and getting ready to release. He's finalizing a version of that that will be Mercatus. So everybody won't have to go and try to find that federal site. You're going to be able to go right to Mercatus and take that required course. So he's finalizing that, so of course we'll send some information out as we are ready to launch that.
Is that a pass through? It just takes you through Acatus to the national course?
You know what, Robin, no, they're actually developing from the materials from the national course. So Indiana has had that training for a very long time. It's been in person and it's been very successful, but all that information is all based off of the federal training. So we'll of course preview that and take a look at it and make sure that it is what we want and that it meets the requirements. So we won't beat this anymore. That's obviously, we talked about the psychological health courses, which we talked about earlier. I have set the PI quarterly updates for the rest of the year. I was going to try to get out the invitation for March today. Hopefully I can go home and get that out. For this month, it'll be March 26th, 9 a.m. to 10:30. And then will be repeated the next day, but it is from 5 p.m. to 6:30. I will send out to all the PIs the link. And we'll also send out, excuse me, an announcement for the rest of the year as well. The new driving simulator has been ordered. So we're hoping that, we thought like June maybe is when we might accept delivery of it. So it's going to take us a little while to get training on that, develop some policies and procedures for that, some SOPs, and figure out, I think the district managers are going to help deploy that. So stay tuned. That's coming down the pipeline.
And it is EMS focused. If
Yeah.
you use the other one, it's set up more like an engine, even though it's had to be, I'm doing a scenario. This will
No
feel
pause
like
on that one. Yeah, ours is just going to be EMS. So I think that's going to work out really great. Quick update on the CIMSO. They're currently working on a national blood transfusion policy, which everybody across the United States will be able to utilize. They're also, I was on a meeting this past week with them, and they are working on, the education is working on student minimum competencies at the EMT level. So right now, there is a discussion about, are they going to require a specific number of hours per course? So right now, the states are weighing in, and there's a survey being done as to, you know, what each state's requirements are. So, but that is coming down the pipeline as well. We have coming up here very quickly, and we're gonna, again, send out the invitation ASAP, but Wednesday, April 9th, that's the week of FDIC. We're lucky enough to have representatives from the National Registry be able to do, again, like we did last year, a Indiana update for our primary instructors. That will be held here at Plainfield from 3 to 5 p.m. on the Wednesday, the 9th. So are we doing a virtual option on that, correct?
They said, I don't think they usually.
I
object, but I'll
don't think
find out.
so, yeah. So if you are going to be down at FDIC, we encourage you to come to that if you're an instructor. And we also are working on, I'm going to have the district managers help. We'll probably use similar locations that we did for the provider forums that we did last year, but we are going to finally have some training institution and primary instructor forums this year. Probably won't start till like June. We want to make sure we give people plenty of time to get it on their calendar. It'll be divided up like we did the provider forums and probably utilizing similar locations just to make life easier if those are available. If you're interested in hosting one, please let us know and we'll see if we can make that happen. SimLab, we have delivery of the new SimLab. Tim has actually launched it. He took it down, I believe, to Evansville. It's been working out really great. We have the rack done on it. It came out really nice. Tim has been having lots of fun with it. You can see the rack there as well too. I don't know, do we have pictures?
Yes, one more, you'll have inside.
Yeah, inside picture. So we have set it up so it's like the back of an ambulance. And there's a bench seat, and so it's, you know, airway stuff's up front. So it's very similar to the back of an ambulance. We ended up, people took it down to Posey County and they allowed us to use some of their pictures from training. And that's it. Anybody have any questions? Yeah.
Just to add on here to SIMSO blood policy,
Yes.
2 weeks from today, Newcastle is hosting a
Oh,
EMS
that's right. I signed up for that. Yeah.
employment education, so.
Yes, absolutely. I didn't sign up for that. So, yeah, thanks for sharing that. Anything else? All right, here we go.
Thank you, Mr.
Cool, right?
Oops, he's not here now, but Dr. Yeagle had his birthday. I'd be used if you've not seen him. He auditioned to be a Colts quarterback years ago, and we feel like that's where they are because they never accepted it. But if you want to reach out and wish him a happy birthday. We had a new administration that began in January. Governor Braun appointed Jennifer Ruth Green as our Secretary of Public Safety. She has different agencies, they call them verticals under there. Homeland Security is included, and she is actually the director of our agency as well. She is designated for EMS Commission, Jonathan Witham, who you recognize as a longtime general counsel and our chief of staff. He is our deputy director now, and he is our EMS Commission designee. Jonathan, anything you want to add?
Yeah, no. I'm glad to be here. In this capacity now, I've played a couple different roles, I think, with you all over the years, so pleasure. I did let my EMT cert lapse years ago, so I feel like if I'm on this commission, I probably need to get that back, so I know some people.
You better do it before the reacquire. That's my only advice.
No, pleasure to be here. Thanks for all that you do for this commission and for reading that.
Brag on myself a little bit. I just passed my 5-year anniversary as state EMS director, so in the early days of COVID. Yeah, I laughed. I like the little graphic, 60 months. We are doing the EMS Division newsletter. Corey is our point of contact if you ever have questions or feedback. Our targeted goal is to do it on April 2nd. We did submit, we have materials there. And we'll have updates from everything, like I could picture information we have here, we can easily start populating into the next newsletter. Goal is to do it monthly. Department of Workforce Development, we currently have a system where they have flames, and so EMS was a 4 flame, which meant we were high. And that made it easier to get grant funding. And they had a WRG program that a lot of I shouldn't say a lot, but at least some EMS programs were using to fund. And it disappeared, and they had reclassified us as a 3 flame. And so we had meetings with them, and I gave them supplemental information. I'm excited to announce we are now a 4 flame again. So the few of the training institutions were very vocal and asked if we could help. We were able to fix that problem so that they have access to those grants. They are going to be switching to top jobs, which I don't know if they're gonna have bars or whatever. I don't think it'll have flames anymore. Yeah. We do have, we're working with, we are the lead, but we're working with Department of Health, Rural Health Association, Indiana Hospital Association on an Indiana EMS and Hospital Preparedness Summit. This is an offshoot from Indiana EMS 2025. The idea is that we would come together and discuss different issues, and you can see them up there. We heard earlier, diversion, for instance, is a big one. Interfacility transfers, where hospitals and EMS connect and sometimes disconnect. The idea is to come together. That'll be on May 29th. It is going to be by invite only. So I don't have registration information. If you are potentially interested, you can reach out to district manager or myself and we will see. But what we're targeting is around 5 people per district. And we want to try to get a workable group of about 50 to 60 people. So we know there are probably a lot that are interested. But I think this will report back. I think this is going to be a very positive thing. The perinatal quality collaborative conference, they want to make sure we invited EMS. They have education specifically targeting. And I believe we may have the driving simulator or one of them going there. I don't remember which one. They didn't take my group. Robin, do you know?
We're talking about the hospital summit.
Yeah. Do you know if the collaborative, are we sending driving simulator this year again?
Yeah.
Or- Okay, so it will be there. Oh, that'll not be our new one. That'll be the big one. It's all good. They also wanted to share, here's their current OB drive times that are either 30 minutes or 45 minutes around the state with some of the closures. So a lot of peak days on there with that. So I just thought I'd share health first, EMS readiness. We're still on fiscal year 2025. Carrie has some exciting programs she's been working with me on, test prep packages. And we're working on a contract with Jones and Bartlett. We're about at the tail end. This is why I don't do contracting as an attorney, because I was drugged through all of it. And oh my gosh, Jones and Bartlett, I was just like, it should not be this complex, but they're like, we're not gonna fold. And Christie would be like, it's against Indiana law, we cannot include that. Well, we need that. We need, like, oh my gosh, we're never gonna have a contract, but we're close. So I think it's in the signature phases. So we have an agreement in principle. We do want to announce, we're excited, as part of fiscal year 2025, we have a program that will cover the first 2 exam attempts for national registry with EMT, advanced EMT, and paramedic. So if they're Indiana trained through our program, then we believe they would be available. This will not be a reimbursement. It'll be a direct bill to us. And so we will have instructions as we get closer. This has started down contracting phase as well. But I think this will be a positive to reduce costs for people that are testing, because as Carrie quoted, you know, it's around $100 at least to test. I will be emailing out a PDF with all this, probably Monday. And I'll go through real quick. We are still getting Bowen Center, and they do have a student data report. Here's some of the highlights. They have the average cost per course about $1,500. And with this, then about 40% had awareness of EMS career opportunities. And then what people are looking to work at, 59% were said potentially fire department, and another 55% said particularly ambulance. So a little more interest in the fire side, and then kind of what their benefits are. I think this could help some providers and training institutions as they figure. We continue to get better student information as we approve, and Corey and has worked with them on trying to improve how we message that. And Robin has spent a lot of time on it, on trying to make sure that we're getting the information to the students and we get them to respond. And so I know Carrie emphasizes it as part of the course completion, make sure people are filling out these surveys. Most of the students, not surprisingly, do not have any prior EMS experience. Obviously, if you're a paramedic, you would have that prior. The anticipated wages and stuff are listed there, as well as the cost of the programs, broken down by EMT, advanced EMT, and paramedic. I thought it's kind of interesting to see the mean cost. Advanced EMTs were not that costly program. I was kind of surprised. Student data, and this is kind of their comfort level, which I thought was interesting, you know, what things are going to challenge them the most. Just kind of interesting to see the percents and things like that as they come out of class. And desired employee setting. Again, the fire service was #1, but a hospital ambulance was #2, third service. And some of their phrases might have confused students too, so you never know on that. And then there's the desired community. What are they looking at if they're going to be employed? The good news, the nightlife is at the bottom of the list, but I don't know if that means like the off duty or what you expect at night when you go out. Cost of living, commute time, and crime safety are key factors that were listed by the students. Kind of the desired benefits, this is where I think employers can benefit from kind of seeing what are the expectations for health insurance, important paid time off, and then the retirement are the big three. I thought it's always innovative how Bowen Center comes up with selection. Gym membership's on there, although it's at the bottom of it. Yeah, that good or bad? We could have a whole side discussion. This is the travel distance for training institutions. When I send it out, someone like Lee can study it a little more because I was looking at the weird arrows, trying to figure out what they were doing, but I may send this out as the original PDF, so it's easier to read. National Registry updates, next Board of Directors meeting in April. We do not have a full directors meeting. It's committee week. I'm on governance and international and only governance is meeting, so it'll be an easy week for me compared to my first year where I had like 5 days of solid meetings. Recertification season for registry. Their certs are due March 31st. And so they approximately 253 pro writers are due to recertify. This was as of a week ago. So they are certainly busy right now. So if you are reaching out to them, you may have a